This conference will now be recorded.
Hello, everyone. This is a module of subfertility, and we are going to discuss about our subfertility module. Let me open my camera.
Good evening, ma'am.
Yeah, good evening. So I want to open my camera, but there's, I think, some problem in it. 1 second.
We can see you.
We can see you. You're already on camera, ma'am.
Okay. Okay, that's good.
We can see
Yes.
you. You're just like a moon.
Okay, let me close it then. I will minimize first. Okay, so let us start this session of subfertility module. And so I like to start from the guideline. We need, first of all, I want to give an advice regarding the people who are going for January exam, for this exam, September exam. So what you need to do is to revise, right? And how to revise at the last moment. You need to revise your guidelines, right? The bold letters which is written on the guideline, it needs to be revised. The summaries, so the homework should have been done from before. All the talk article summary needs to be revised, and some things like Faculty of Sexual and Reproductive Health guidelines, which is contraceptive guidelines, all of the things, the bold letters needs to be revised. Some people are making their notes, and some people are writing like bullet points in front of their guidelines. So the way that you use to revise, you need to revise. And this is the time to do the recalls. Now, why I'm saying that doing recalls are important? Doing recalls are important because you will get used to the exam and doing as much mock exam as possible. And so the recalls are coming, sometimes 10% of them are coming, sometimes 15% of them are coming, sometimes 20% of the recalls are coming in the exam, the real exam. And sometimes it is coming exactly like before, and most of the time they will change something and then they will give the same topic. So I recommend discussing about recalls than doing the recalls only. I mean, the answer, question and answer. So discuss about a recall. For example, if you have a 2019 and 220 recall, yeah, sorry. So because the meeting is full, there are many people want to join. Unfortunately, the maximum is 150. So if you are doing a recall, you discuss about a recall with your study partner. Now there are Telegram groups. There are many people who are mentors are discussing recalls with you because the answers are with the RCOG. But fortunately, you have mentors who are discussing recalls with you. So go and do the recalls for the people who are going for September exam. For the people who are going for January exam, they still have they still got 4 months, which is it needs 6 months, 4 to 6 months. So you exactly have the time which is needed for the exam. So you for the people who have not yet have started, they should start now, because I think it's a little bit late for them to start. But it's never too late. So you should start now. You should start now. And how to start? Whenever you read any guideline and whenever you read any talk article, what you have to do, you make up your own EMQs. And while we are reading the guideline, I will show you how to make your own EMQs out of this guideline or out of this talk article. So you discuss a guideline with your reading is not enough. So you have to discuss it with your study partner. And while you are discussing the guideline or a TOG article, you need to make up your own EMQs based on the knowledge of recalls. So you should have attended the recalls before you start reading and making your own EMQs out of it, because the main problem is not SBA. SBA is simple recall of memory. It's epidemiology, the statistics, the numbers. The main problem is EMQs, in which people find difficulty, isn't it? So this is how I did, and this is how I'm teaching, and I'm asking the people to do it. That other mentors cannot just, because the recalls are coming, they are repeating it like 10%, 15%, not more than this. So you make your own recalls. In this, you can cover the whole EMQs out of all topics. Yes, there is help available. Mentors are giving a lot of mock exams. And so with the help of these mock exams, so they will not come exactly like this in the exam, isn't it? So they will give different EMQs every time. So you have to make your own EMQs. What is the material that you will go through? You go through the guidelines, whatever the guidelines available in RCOG site. Then the second thing is TOG article, and the third thing is strategy. If you don't find a topic from, so you need to finish your syllabus, which is given in your RCOG site. If you don't find a topic in any of these places, then you switch to any textbook or the other article, or the other articles like BJOG or current, which is called reproductive, what you call it, there is a new name for current. So you look for the other articles. But first, I think for most of the things, 99%, these three sources are more than enough. And there is a lot which is given, every time the guidelines are updated. Look, this guideline is updated in 2020. So they are updating all the guidelines. It's all information is updated in the RCOG site. Strategy is continuously updated. It's a very good source. TOG articles are very informative, and many EMQs are coming from, not only from the guideline, a lot is coming from the TOG articles. Okay, let's start our topic. Regarding infertility or subfertility. So we call it subfertility, not infertility anymore. We should know, because these things comes in SBAs. For example, infertility affects 1 in 7. We are talking about heterosexual couples in the UK. The main causes of infertility are, so we will be talking about unexplained infertility, which is 25%. We will be talking about ovulatory disorders, in which premature ovarian failure and PCOS, for example, 25%. Tubal damage, which is 20%, which causes tubal block. And factors in the male factor is 30%. And there is uterine or peritoneal disorders. The main thing is endometriosis in it. And 40%, so whenever a patient comes to your clinic and you are sitting in an infertility clinic, you are covering your subfertility clinic, 40% you will find in 40% of the patients, both men and women will have some problem. Both of them will have some problems. Problem and female, they are combined. So please, I want all of you to mute your mic, because I'm getting disturbed from the voices. Okay, so uterine or endometrial factors, gamete or embryo defects, and pelvic conditions such as endometriosis. These are, they can be any problem. I mean, the semen analysis problem, the endometriosis in female, PCO in females, whatever. So we have to do the investigations. Still, there are many people, there are many, not only candidates, people who have passed the exam also, and who are sitting in subfertility clinics. Sometimes they don't realize, or maybe they don't remember what are the basic investigations. So I want, can everyone mute their mic? Okay, here we go. So the basic investigations you need to know. The semen analysis is basic. Assessment of ovulation. So how you assess ovulation? Can anyone answer me? By doing what kind of investigation?
That is by seeing the level of the hormones like follicle stimulating hormone, luteinizing hormone, and like
Do you think that FSH and LH is
Day 21 progesterone.
is
yes, progesterone can also be done.
is
And
in baseline investigations? Do you really think so? Is included in yeah. And the baseline investigation includes day 21 serum progesterone. This is what they are referring over here. And for tubal damage, hysterosalpingogram. So many people are starting Clomid as in practice, and they are not doing hysterosalpingogram, and it is part of baseline investigations. And uterine abnormalities, how you will know? You can ask for an ultrasound, transvaginal ultrasound, and you will know the uterine abnormalities, right? And screening for infections like chlamydia, especially if there is a high risk history and susceptibility to rubella. So again, my question is how to when to do FSH and LH, and it is written in the guideline.
And when the patients present with irregular menstruation, then you can
Yeah, it is
do the
guide.
gonadotropins.
Yes, this exactly. I know there is a practice. If you are sitting in a fertility clinic, what you will order prolactin, you will order TSH, you will order FSH, LH, you will order maybe some people do order hysterosalpingogram and some people don't order. You might order day 21 serum progesterone. And an ultrasound, right? And semen analysis. So not everything is baseline. Prolactin and TSH is not baseline, and this what you call it, FSH and LH is not baseline. So we should understand what are the baseline investigations according to the guideline. And you do whatever is your practice, but in exam you have to follow your guideline, isn't it? So once a diagnosis has been established, so you fall the treatment into 3 types. There is medical treatment, ovulation induction, everyone knows. Surgical treatment, everyone knows. Laparoscopy, and then there is ART. I want to ask, what is the definition of ART? ART, assisted reproduction technique. What is the definition? It includes what?
It includes handling of the gametes and embryo outside, other than the in the outside environment.
It excludes IUI.
Like except vaginal, excluding the vaginal environment.
Vaginal intercourse, right? So, but it includes what? This is the definition, the book definition. So, it includes what? Is ovulation induction with Clomid and timed intercourse is included?
No, it is. It includes IVF, ICSI.
Yes, and
IUI.
Gift.
IUI.
IUI is included.
Is included. There are many people, they don't know what is included in ART. They are reading ART everywhere, and we all of us are using this term frequently, but we don't know what is included in ART. So IUI is included because it do not involve the vaginal intercourse. You know the procedure of IUI, all of you knows, right?
Yeah.
So it is included, IUI, IVF, ICSI. So what is the initial advice? Initial advice, once the patient comes, you will counsel her. What you will counsel her? If she is less than 40 years of age, that 80% of the couples conceive within 1 year. Many of the patient you will see that they are coming after 6 months. If you see that she might have a comorbidity, for example, she never had a period, maybe she is having premature ovarian failure or whatever, or maybe she has severe dysmenorrhea, dyspareunia, and you're suspecting endometriosis, you will start to treat her early, investigate her early. But usually, if you think that she's not having any of the problem from the history and examination, then you can counsel her. You can tell her to wait. And if her age, what is the age limit? That you will tell her, okay, now you need to start investigating. We will investigate you, although you are 6 months or 7 months married, but we will start to investigate you. So what is the age limit?
35
More than
years.
35.
40.
Yeah, 36. Okay, 36. According to the guideline, according to the TOG article, so more than 36 years, you start early. And if you suspect any comorbidity, and then you start early also. Now, otherwise, tell the patient that 80% of the couples will conceive within 1 year. If she is less than 40 years of age and they are doing not using any contraception and they are having regular sexual intercourse. Of those who do not conceive in the first year, half of them will do so in the second year. So the pregnancy rate will be over 90%. Inform people who are using artificial insemination to conceive and who are now the topic changes and they are talking about artificial insemination. 1 second. But first of all, I want to ask you, what is the definition of subfertility or infertility?
In
Okay.
subfertility, there is
Because
a
in the guideline, the information is scattered here and there, but we need to follow our pattern. So what is the definition of infertility?
patient who is not able to
After
conceive
this,
is
yeah.
infertility. In subfertility, there is a ability to conceive. There is a chance to conceive in subfertility. But infertility, there is no chance of conception.
So it's the same thing, first of all. Subfertility or infertility is the same thing. But because it's considered, what you call it, the infertility is not a very nice term and it's considered a stigma. So they changed the word to subfertility, but it's more or less the same thing. So tell me the duration after this. You say that now you have subfertility or infertility, and now we are going to investigate.
After 1
1
year
year.
of unprotected intercourse.
Yeah. So what is the definition? Can someone tell me the definition?
Inability of couples to achieve pregnancy after 12 consecutive months of unprotected sexual intercourse.
Yes, exactly. Perfect. So we first of all, to understand anything, we should know the definition, right? And a woman of reproductive age who has not conceived, and it is written in the guideline. The definition is written in the guideline, but the thing that they are not writing it as a definition. They just gave it and they say that just a statement, but it is actually a definition. So what is the definition? A woman who is of reproductive age, not conceived after 1 year of unprotected vaginal sexual intercourse in the absence of any known cause of infertility. It is written in the guideline, and this is exactly is the definition of infertility or subfertility. It's the same thing. So let's come back. We are talking about artificial insemination. Can anyone tell me what are the two kinds of artificial insemination?
Intrauterine and intrasperm.
Intrauterine and intravagine.
Cervical. Yeah. So intrauterine and intracervical. So IUI is done in the clinics, right? So you cannot do it at home. What about intracervical? Can the couple do it at home?
Yeah,
Yes.
Yes, a couple can do it at home. There are devices, syringes, kind of syringes, and so they use the raw semen and they push it in the near the cervix. This is how they do, and there are kits available in market for this. So, what is the indication of artificial insemination? The three absolute indications. I'm asking very basic questions. These basic questions I find many of the gynecologists who are doing infertility clinics also sometimes they are not able to answer. So you should have your base, strong base, so that you will not be ashamed after you will be sitting in your clinics, right? So what are the
Where
indications
there
of
is, where there is
Problem with
inability
sexual activity.
to have vaginal intercourse.
Yeah, there is
One,
problem with
and
the
two,
vaginal
if they have same-sex relation,
Yeah, so one is same
and
sex
if
and the other one
yeah,
is problem, physical
physical
disability.
physical inability to have sex or contact, like she has some physical deformity or some other problem where
and
the
surrogate mother.
sexual intercourse is not possible.
Impotence or anything, or retrograde ejaculation,
Yeah.
and what
Erectile
else?
dysfunction. And the third
Erectile.
one is where we need to give
Surrogation.
like
Surrogation.
HIV, and where we have to give an like washed sperms, and for that we need to go for an IUI.
That's true. Yeah, you
And
mean if the man is HIV positive and he's
yeah,
not fulfilling the criteria. Yeah, that is true. Exactly. These are the three absolute indications. What are the three relative indications of artificial insemination or IUI, you can say? What are the three relative indications that you can do it? I mean, not absolutely, but you have option. You can go for IUI. What are the three?
Unexplained infertility, mild
Yes,
male,
exactly.
mild male
Exactly.
Same-sex
And the
couple.
third one?
mild endometriosis also.
Yes, mild endometriosis, unexplained infertility, mild male factor, and mild endometriosis. These are three relative indications. So I want to make it very clear to everyone that some people are doing IUI for PCO. So is PCO is an indication for IUI?
No.
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 So we are now very clear.
No.
We are now doing it, you know. But I want you to be very clear about the indications of IUI. So it is not written in this guideline, but it is written in talk article. It is written in talk article that what is the success rate of a single IUI?
It's around 9%.
Mm-hmm.
9%.
Yeah, you can say 10 to 15%, between 10 to 15%. If you don't remember any percentage, you know the trick. You see, it's either 5% or it's either 10% or maybe maximum. So you can guess, you know, if you have some idea, you can guess. So don't say 9%, you can say around 10%. Your answer will be most probably right. So, okay. So we can see from here that over 50% of women aged, and now we are talking about a woman under 40 years, right? Over 50 years of women aged under 40 years will conceive within 6 cycles. So if you do IUI, you have to inform the woman that once, if you do it once, it's 10 to around 10%, the success rate. But if you do it 6 cycles of IUI, I'm not talking about intracervical. If you do 6 cycles of IUI, the success rate is, or the pregnancy rate can be over 50%. This is how you will counsel a patient who want to do IUI, right? And the other thing is that if she continue to do it for another 6 cycles, then the pregnancy rate will become over 75%. It means from this statement, it means that the person can have 12 cycles altogether of artificial insemination, isn't it?
Yes.
Yeah. But what practically happens? What happens in your clinic? Are they going for 12 cycles?
No.
After 2 or 3 cycles, they will say, okay, we want to do IVF, right? Because they don't have patience. But you have to counsel a woman that if you want 50%, then the success rate will be over 75%. If you want 50%, then the success rate will be over 50%. success rate or pregnancy rate, then you have to do at least 6 times. Otherwise, go directly for IVF. Okay. Can you still hear me?
Yes, ma'am.
Yes,
Yes, we
yes, we can
can.
hear you. Yes, I
Hello?
can hear you. Yes.
Yeah, if you
But your
cannot
voice
hear me,
breaks up.
please write a message so that I can turn off my camera, because sometimes the network gets slow. And by switching off the camera, then you can hear me well. So please do tell me.
Your voice is breaking
Okay,
up in
so inform women. It's breaking up. Shall I stop my camera? It's not important for you to see my face. My voice is more important, right?
No, ma'am, it's okay.
Okay,
You can
I switch
continue
off
with
my camera.
We can hear you perfectly well.
Okay, okay. Later on, I will open my camera. So inform women who are using artificial insemination to conceive and who are concerned about their fertility that using fresh sperm. So what to use? Should you use fresh sperms or frozen? They are saying using fresh sperm is having higher conception rate with artificial insemination. Okay. Now, and IUI is better than intracervical insemination in terms of success rate. What you will counsel the woman? The couple, sorry, because whenever you see a subfertility or infertility, you have to see them as a couple. So you will tell them that the frequency of sexual intercourse should be every 2 to 3 days. Now, alcohol. What is the, you should know the limit. Sometimes it's coming, they're asking in SBA. So what is the limit for the women who are trying to become pregnant?
1 to 2?
Yeah, not more than 1 or 2 units. You can remember like this. So she can have like 1 unit or 2 units once per week. Or it is better, she can have twice per week, but you can remember like this: once per week, 1 unit or maximum 2 units. And of course, avoid intoxication. For men, it's a little bit Department of Health have recommendation for them. So it is per day, not per week. So people are sometimes get confused in per week and per day. So it should not be more than 3 to 4 units per day for men. What is the meaning of semen quality? Can someone tell me what is included in semen quality when they talk about semen quality?
Normal forms, normal motility.
Its volume,
Hmm?
its motility, its morphology, its
Yeah.
its number of the spermatozoa count. That is the sperm count. That is
So
almost about
some
1.5
people
million.
think that count not included, but you are absolutely right, sir. Count
Motility.
is
It's
and
motility.
yeah, some people think that it's only motility. Quality is only motility, but quality includes count also.
Yes, ma'am.
Okay, this is good that you know, because because you know we are assuming ourselves this is quality and this is quantity. So count is something else. No, when they talk about quality in a guideline, they talk about everything. Okay. And smoking. Women who smoke should be informed that this is likely to reduce their fertility. So alcohol, smoking, everything. Women should be informed that even passive smoking is detrimental. Stop smoking is good for general health. Now, caffeine, tea, coffee, the caffeinated drinks, cold drinks. So there is no consistent evidence of an association between consumption of caffeinated beverage. So women who are trying to become pregnant, can she take tea and coffee and colas? Coca-Cola, Pepsi, can she?
Yes, ma'am.
Yes.
Yes.
No problem.
So if a woman is going for IVF, what you will tell her? Can she take tea, coffee, and colas?
No, she should avoid them.
I want you to realize it is written in the guideline. Sometimes many things are written in the guideline, but we don't realize, you know. And it is written very clearly that the people who are having fertility problem, they can have tea and coffee. But for the people who are going for IVF, they should not. So this is the difference. Obesity. Women who have, there is a clear cut BMI 30 or over. So I want to ask you, a woman whose BMI is 30 or over, and she's not PCO, she has a tendency of delayed conception or not, just because of her obesity?
Yes,
Yes, there is a
she has a
possibility.
tendency of.
Yeah. So the answer is yes. The answer is yes. Only obesity, which means BMI 30 or more than 30, is going to affect her fertility. So you have to inform the woman that you need to reduce your weight, right? Especially if PCO with obesity, this is on top of it another problem. And of course, you will ask her to reduce weight. But even only obesity, which means BMI 30 or more, is going to delay her conception. Okay, so women who have a BMI of 30 and who are not ovulating, which usually happens in PCO patients, should be informed that losing weight is likely to increase their chance of conception. So what you have to do, you have to inform them about a dietary plan and exercise plan. What about men? Whenever you take a history in an infertility or subfertility patient, you take male history. What questions you will ask from a male? Can anyone tell me in history?
Age of the male,
It's
occupation,
Yes.
smoker or non,
Occupation. Yes.
taking alcohol or not, any history of
Yes.
surgery lower down in the groin, or comorbidities like diabetes, hypertension, whether using beta blockers, and doing exercise and using steroids.
Yeah. So what is the role
Also
of weight?
fathered a child.
If the man is obese, is that going to affect his
Yes,
fertility?
Yes.
yes, yes.
So you take record of his weight also. And there is one more question which sometimes we miss, that if he fathered any child before. So all of the questions are fine. There are only 6-7 questions that needs to be asked, basic questions. And of course, medications are important because some medications reduces they causes sexual dysfunction, and they might affect the prolactin level, and some medications cause impotency and other problems also. So of course you need, and steroids, anabolic steroids, people who are doing exercises and they want to build bodybuilders, they're using anabolic steroids, and it affects the semen quality. Okay, so low body weight. So what is the lower limit? 19, less than 19. So if it is less than 19 and they also have irregular menstruation, or they are not menstruating, should be advised that increasing body weight is likely to improve their chance of conception. So what about a woman who have regular menstruation and her BMI is 18 or 18.5?
It should be beyond more than 19.
Is her BMI.
There is something in diet, calorie-rich diet, to make the BMI normal.
From this statement, what is written in the guideline, what I understand, of course, if some patient comes to my clinic and if I find her BMI is 18 or less than 19, I will ask her right away that you should need to increase your BMI, right? But I have to see also if she is menstruating or not menstruating, or irregular menstruation. It means she's not ovulating, most probably, if she's having irregular menstruation or no menstruation. So that's why it is more important, if she's having menstruation problem, that she should increase her weight. It means she's not ovulating. And there are some habits of male, not only occupation, but there are other habits that you need to ask also. Occupation is important. Like they are working in a factory in which there is the environment is hot, or for example they are using some over-the-counter recreational drugs, which is mentioned here, so a few of them. So medication history is important. Many people will come to you and will ask you, I'm using this herbal medication. So what you will tell them? That
there is no scientific evidence.
they are not properly evaluated and further research is needed. You cannot say no and you cannot say yes, because you will say further research is needed and they are not yet properly evaluated. That's why I cannot write for you and I cannot recommend also because of this, because it's not a no, but it's because further research is needed. So folic acid supplementation. So it is how much? 400 mics per day. But there are some women that you need to give them 12 weeks before they are trying to have a baby, 3 months before, 5 milligram. So there is a list. A woman who delivered before a child with neural defect, or they are on anti-epileptic medication and who have diabetes, and PCO patients who are obese, they should take 5 milligram. These 3 or 4 women should take 5 milligram, not 400 mics. So this is the investigation. We already talk about it. Okay, a woman of reproductive age who is using artificial insemination to conceive, either from her partner or from donor sperm, should be offered clinical assessment and investigation if she is not conceived after 6 cycles of treatment. It means that she can have 6 cycles of maybe intracervical insemination at home before we will do further investigation on her, in the absence of any other known cause of infertility. Where this is using partner sperm, the referral for clinical assessment should include her partner. Okay, so offer an earlier. So these are the women. I asked you a question earlier that what are the 3 kinds of women that need early referral? The woman aged 36 years or over, if there is a known clinical cause of infertility or a history of predisposing factors for infertility, and where treatment is planned that may result in infertility. So she's going for cancer treatment, chemotherapy, which is going to damage her ovaries. Then she needs to be referred early also. What about the woman who her partners are having hepatitis B, hepatitis C, or HIV? They need to be referred to a facility where they can have facility, because the semen analysis needs to be, I mean, they need to sterilize the area, the centrifuge machine, and they should have separate setup for them. So investigation of fertility problems and management strategies. So what about the semen analysis? I have questions and I want to ask you, because there are people who don't know the cutoffs. So what is the cutoff of semen volume?
1.5 million.
1.5.
Yeah. For the people who read the previous WHO criteria, but and it's long time back, they still have this in their mind. It was 2 ml, but now it is 1.5 ml. So what is the sperm concentration, which is per
15 million.
15 million. 15 million.
15 million per
So you should remember it by heart. Yeah, 15 million per ml, not per ejaculation. Per ejaculate, one ejaculate
39 million. 39 million per ejaculate.
ejaculate is total sperm number, which is 39 million. Because in SBS, it can come in million with perfect. And unless you know the normal, you will not be able to answer.
There is a lot of noise. We can't hear you.
Let me see who's.
Nisrin Muhammad.
Okay. I think it's no more.
Yes, it is better now.
Yeah, there are some other people who are not also muting. Okay. Okay. So I have another question. The total motility. So it includes progressive and non-progressive motility, both.
40% for the
What is
total.
the
Total.
The total motility should be 40%,
Yeah, it is
and
40%.
our motility.
If it's
And
progressive, it's
30, 32 for the progressive.
Yes.
Yeah, so you should remember these two. 40% for the total, which includes non-progressive also, and there is 32% for the progressive. So you just memorize. It's a matter of memorization. You just need to memorize it. And vitality is important also. How much should be alive or
58.
vital?
4%.
58%.
4%.
58.
58%. Sorry.
58%.
Yeah, it is 58. It is 58%. And morphology. What about morphology?
4%.
Tell me the
4%.
Should be normal.
average
4%.
and tell me the range. What is the range?
4%. No, the
Now I
range
will
is something else.
separately. Is 2% acceptable?
No. No,
No.
no, no. Less
Yes.
than
The answer
more than 4%, I think.
4 to
4%.
10% should be
is
normal. 4 to 10%.
now, is the 3% is acceptable?
No.
No.
Should be 4 or more.
Okay. Can anyone agree or disagree
With?
about 3%?
No, I don't.
It's not acceptable.
No.
It is
Okay.
not
So
acceptable.
Should be 4 or more percent.
4 or more, yes.
It has stated about 4%, so it can be less than that.
It is still acceptable if the motility and the motility and the account is okay. It's
yeah, that is absolutely right. So there is a range, you know. Do you know about the range? Have any idea about the range? That this range is acceptable.
No.
And it starts from 3%. So there is a range which might be written here in the guideline. I do not include it, or maybe I read it from the laboratory in report, that there is a range, or maybe from the, I don't know from where I read it, that I want you to search more about it. But I read that the lowest limit, because in range there is a lowest limit, right? The lowest limit is 3%. And I want you to search more about it and then post in the group if you disagree on this. So what I read and what I know, that the lowest normal limit starts from 3%. The
Ma'am, is
thing
that for
about
the
okay,
ma'am, is that for the
yeah,
morphology that you have just told?
morphology, yeah.
Okay.
Whatever you said about the limits, cutoffs, they are all right. So anti-sperm antibodies not important.
No,
So if the
antibodies, no,
first
we
semen
don't do.
analysis is abnormal, we don't do it. No one do it. So if the first semen analysis is abnormal, when to repeat it?
Within 3 months.
Yes. So if it's a mild abnormality, do you know the cutoff of mild abnormality and severe abnormality? In guideline, they are talking about mild
There is less than
abnormality,
5.
right?
less than 5 million.
Severe abdomen.
If mild,
Yes.
repeat, it should be after 3 months. If severe
Yes.
abnormality,
If mild
should be as soon as possible to repeat.
Exactly. And do you have any cutoffs? It is given in the TOG article.
Yes,
A
from
cutoff for
5 to
mild.
15, it's mild to moderate, and less than 5, it's severe. Million.
That is exactly true. True. And it is, of course, it is written in, it is given in the TOG article. So we are not making it from our mind, right?
Yes.
Okay. So So the repeat confirmatory test, as it is said, is after 3 months. And of course, postcoital testing routinely, it's not recommended. We don't do it. And as it is written severe, because in the guideline they are using the terms mild, severe, but they're not giving the explanation. You find explanations from the TOG article. So you can never ever, you can never ever get a full idea about one topic by reading from one site, by reading from one guideline. One guideline is not complete for a topic, to understand a topic very well. To understand a topic very well, you need to combine 2 or 3 sources, always. This is the rule of thumb. So use one of the following measures to predict the likely ovarian response. So you have to, if your patient is going for IVF, so it's not for every patient who comes to you, okay? It's for the patient who is going for IVF. You have to see that he has ovarian reserve or not. And what the 3 tests to check for ovarian reserve are: total antral follicle count should be most likely to predict the likely.
4. More than 4.
Yeah. So I'm asking you one thing. So if any woman is having 3 in both ovaries, total 3 follicles, can she go for IVF?
Yes.
No.
No.
Should be.
No, it should be
Yes or
More
one
than
ovary.
4.
Yes.
No.
Can we concentrate on the first line? So total antral follicle count of less than or equal to. So you need to concentrate on these things: less than or equal to. If it is written less than, it's okay. But if it is written equal to, then it means equal to 4. So total antral follicle count of less than or equal to 4 for a low response and greater than 16 for a high response. So you are predicting ovarian response while you're giving the gonadotropin stimulation and IVF cycle, right? So if it is 4 or less than 4, you can say like this: 4 or less than 4, then you predict a low ovarian response. A low ovarian response. Does it mean that if some woman has 3 follicles, are you going to offer IVF for her or no?
We are going to offer IVF, but the response is going to be less.
Yes, exactly. So some people, they misunderstand. So they misunderstand that if a woman has 3 follicles, usually as a fertility specialist, we don't start IVS once we find the follicles are like they make a cutoff. Like we are saying 3 follicles maybe, but not less than 3 follicles. We don't do it, right? Because it's not worth, because there's a procedure involved, there's money involved. I want to ask one thing more. In NHS, in UK, because we are talking about UK, uh, this is a UK exam, right? So in NHS, how many cycles are free of cost? And what is the criteria?
Before,
Cycles.
according to the age, 3 cycles. More than 40, it's only 1.
2 cycles.
Okay, according to the age. So less than 40 years of age, for example, if I want to know less than 40 years of age, how many cycles?
3.
3 cycles.
Cycles.
It is 3. It is 3. And
3.
what is
Yes,
the
ma'am.
criteria? Age should be less than 40.
40
Is there any
years.
other criteria? If a woman has a child from her previous partner before, is
No,
she
they won't
eligible?
fund.
She's not eligible.
No, they won't fund it.
She's not eligible then.
So primary
She should
infertility.
not have a child.
This is the first criteria. Second is second is age. And what is there a third one? Is there any other criteria?
And she should not have a low ovarian reserve also. If she's more than 40.
Yes. So you have to do the ovarian reserve test. If she is more than 40 especially, and she is having a low ovarian reserve, then also. What about the obesity?
BMI more than 30, they
30.
do
Yeah,
not
we have a
fund.
cutoff. We have a cutoff, right?
Between 9.5 to 30.
19 to 30, between 19 to 30.
19.
Should be between 9.
Yes, exactly. Because is 19 included? If she has a
Yes,
BMI,
19.
Yes, yes,
19.5.
Yes.
19 is not
yes.
included.
19
No,
is not.
19 to 30.
So please concentrate on these small things because they said less than 19. So it means 19 is normal.
Yeah.
So just concentrate on these small things because sometimes they are asking about, at the cutoffs. They want us to concentrate on these points. So AMH, if it is less than 5.4 pentamoles per liter. Now the people who read the AMH talk article, I want to ask them that there is one more unit of AMH. Can anyone tell me? And what is the lower limit of that unit?
Gram, and it's 1.
This
1
one,
to 3
2.5.
is normal.
what is the other
2.3.
unit?
Nanogram, mg per ml.
Okay,
And it's
per
less
ml.
than 1 is abnormal. Less than 1 is lesser. 1 to 3 is normal.
Mhm. Is it 1 or is it 1.5? Just making, because I'm always thinking that 1 up to 1.5 is less than 1.5 is low. Maybe I will correct myself. It is in the TOG article, by the way. So for the people who read and who are sure about this information, can anyone share? Because I always thought that less than 1.5 is low. So this is another homework. Can you make sure that if it is 1 or 1.5 for a low response? So I remember like this in pentamoles per liter, 5.4 is for low response and 25 or more is for high response. And there in the TOG article, if you talk about milligram per ml, it is, I think 1 or 1.5, whatever, is for low response, and anything more than 3 is for high response. High response means what? What kind of patients are having high response?
More types of
With a good
more
amount of ovarian reserve.
More chances of ovarian hyperplasia.
More number of follicles.
More chance of
more
ovarian
number,
hyperplasia. Yeah, more number of follicles. PCO, yeah, this is what I want to hear. So in PCO patients, there is a risk of
OHSS.
Ovarian
OHSS,
hyperstimulation.
especially if AMH is more than or equal to 25. It's a prediction of high response. And FSH, what is the cutoff of FSH? So if someone FSH is 8.9 exactly, is it an indicator of low
That is a
response?
low response. Yes, 8 to 9 is low response.
Yeah,
Low
exactly.
response.
So it should be more than 8.9. More than 8.9 means what? 9, right?
Low response.
So anything is, yeah.
Ma'am, can I ask one question, please? There's a doubt. We are coming up across in so many questions. If AMH is 25 or more, it is a high response and a high risk of OHSS or a low response?
It is for high response. High response means OHSS, ovarian hyperstimulation syndrome. It usually happens in
More
high
number of
school.
follicles will be formed. So
And
more
what about
chances
the
of
IVF
OHSS.
outcome? Good outcome it indicates?
Talking about outcome, the outcome depends on many things. Outcome depends upon the ovarian reserve, it depends upon the age, it depends upon the BMI, and the years of infertility, the number of years of infertility. So outcome depends on many things. But yes, it depends upon because at the end of the guideline, I want to show you one thing because we are talking about this very interesting thing that you asked. Let me show you one thing. What is written over there? Here. Look what is written at the end of your own guideline. Poor response defined as less than 4 oocytes.
Right.
So
Right, ma'am.
this is response. This is not the follicles to start with. So if you start your IVF protocol and you recruit less than 4 means 3. You recruit 3 oocytes, then it means that this is the definition of poor response. And if you recruit 15 or more than 15, this is the lower cutoff, right? It means that you are going to have high response, which is she's going towards OHSS. This is written as it is in your own guideline at the end.
That's correct, ma'am. Just because we are coming across this question that AMH is high, like 25, and what option we have to choose? We have to choose a good response with a high risk of OHSS or a poor response with the high risk of OHSS. That is the confusion, actually.
The problem with the high response means you have high risk for OHSS. And there is a whole guideline and there is a whole talk article talking about how to prevent OHSS, right? This usually happens in PCOS patients. There are many things you can do. From letrozole, ovulation induction instead of SCG. You can ask her weight even before starting the IVF, before starting giving her ovulation induction. You can ask her to reduce her weight, and you can choose the protocol. What is the best protocol for the patient who have high risk for OHSS? Can someone tell me? There are 2 kinds of protocol, basically 3 kinds.
Short.
Antagonist protocol.
Antagonist. It is antagonist protocol.
Agonist trigger and freeze
And
all.
what about trigger? Because usually we trigger from HCG, right?
Yeah.
So if you want to avoid OHSS,
We'll
how
give
you will
trigger as agonist, TNRH agonist.
TNRH agonist trigger.
Yes,
Yeah,
yes.
and if you see that if there is a certain limit of estrogen, which is the cutoff is written in the TOG article. What is the cutoff of estrogen? E2, that you need to cancel your cycle or you can coast it. Do you know the meaning of coasting? What is the meaning? You can coast.
We continue producing the
reduce the dose of the stimulation.
This is coasting.
Yeah, coasting means either you stop, for example,
gonadotrophins are
you're giving
stopped.
gonadotrophins, you can just stop giving her gonadotrophins for 1 or 2 days. Now you can stop gonadotrophins for how many days? Or you reduce the dose. If you want to stop, for how many days you can stop without affecting the outcome? What is written in the blog article?
3 days.
3 days. So there is a cutoff of everything. You just need to concentrate. This is all not from my mind, so all written in the TOG article. So if you stop gonadotrophins for more than 3 days, it's going to affect your success rate, right? Your outcome. So usually we stop for 1 day or 2 days maximum, not more than this. Sometimes we cancel the cycle and sometimes we freeze. So we go on for the procedure. And then what we do, we will not do the embryo transfer after ovum pickup, and we freeze all. So in the in the laboratory, the embryologist will create embryos, and the good quality embryos, they will freeze all. So this is an option also. There are many things that it is all written in one of, this is the TOG article is very best article for prevention of OHSS. And it is not written everything in the guideline, but if you combine guideline and the TOG article, you will find all the answers. So what is our cutoff of FSH? FSH should be, for good response, should be more than 8.9, means 9, starting from 9, right?
Less than 4. If it is more, then it is low response.
Yeah.
No.
Then it is low response, yes. If it is 9 or more, then it means it is low response. Greater than 8.9 means 9, right? So if it is 9 or more, it means low response. So we know as FSH is increasing, the response is decreasing. It means she is having less ovarian reserve. So if you have,
Ma'am, sorry, you said estrogen level cutoff was what? Sorry.
I don't remember exactly, but I think it is of the value of between 3,000 to 5,000. It should be ideally 3,000 and less pentamoles. I think if I'm not mistaken about the units, because sometimes I'm confused about the units, but you need to remember you are going for exam and I passed my exam already.
Okay. Yeah. Okay. Thank you.
Anyone remember the unit of E2?
Picomole per liter.
Picomoles, I think.
Yeah,
Picomole per liter.
per
Yeah.
ml, something like this. Yeah. So if it is 3,000 or less is fine. 3,000 to 5,000 is a gray area. You can or you cannot. And more than 5,000 is usually means high response. And it is written in the TOG article. You can get all information from there. So what is the regularity of menstrual cycles?
Please, ma'am, before we move ahead, I have a question.
Yes.
Before we leave the area of ovarian response, please, out of AMH and FSH, which one is the best predictor of ovarian response? Because I once saw it in one of the SBAs and I was quite confused because of varying answers provided.
Yeah. So there are 3 ways, and it is written use one of the following. Use one of the following measures. So according to the guideline, you can choose either one of them. But if you ask me, and if I want to know that in future, what will be her ovarian reserve, it means AMH is showing future. We don't know after 6 months, we don't know after 1 year, we don't know after 5 years when when her ovarian reserve will finish. AMH will not tell you this. AMH will tell you that her ovarian reserve is going to finish soon. And there is a cutoff for this. This is for future. But if you want to know in current present, this is what I do in my practice, clinical practice. If I want to know currently what is her ovarian reserve in this cycle, I do FSH. So if I want to know that how much time he has, maybe she want to do IVF after 1 year or 2 years or 6 months. With this patient, I will ask. But if she want to go for IVF next cycle, I will ask for FSH. This is more than enough for me. I will not ask for AMH. Because the FSH will show me the current status of her follicles right now. What is her status? I want to ask you one more question because we are talking about FSH. Is FSH is variable cycle to cycle?
Yes, it varies in the cycle. So it should be done in the early days, 2 to 5 days of the cycle.
From day 2 to 5.
Day 2 to day 5 of the cycle. If it comes higher or abnormal, you can say, should be repeated. And after how long should be repeated?
4 to 6 weeks.
4 to 6 weeks.
Yes, we should repeat it to confirm because there is a variation. You might find an abnormal result and after some time you might find that the result is normal. Or you can do one more thing. If you find that it is high, you can ask, and if she cannot wait for 4 to 6 weeks, you can ask for AMH. And as simple as that, sometimes the patients are coming to me and they will say, no, I cannot wait for my next cycle. I want to start now. I will tell them, okay, let us do your antral follicle count from day 2 of the cycle. And if I find at least 3 follicles, I'll start day 2 your antagonist protocol. In the same cycle, you can start by doing because you need only one of the following 3, right? Okay, there is a sound.
Someone.
Allow one candidate to participate because there are a lot of noise from microphones.
Mute all. It is written mute all, but I need to see one by one who is not. So this is responsibility of everyone to mute their mics because they cannot search for all this 151. Although it is written muted all. Now maybe it is all muted. Yes. Okay. So any one of all are equal. If the patient want to start from the same cycle, her IVF, you can do it day two ultrasound, and if her count is 4 or more, you can start. If she can wait for the next cycle, you ask for FSH or even AMH, whatever. FSH is more than enough, and if it comes high, and if she cannot wait for 4 to 6 weeks, you can ask for AMH. So you have one of the choices. You cannot say what is more better, because you can, according to the situation of the patient, if she can wait or she cannot wait, you are in a hurry, you can do either one of this.
Hello, ma'am.
And while we will do the recalls, you will know better that what kind of, sometimes we don't understand the question also. This is another thing. So any question regarding AMH, because there is a whole talk article about AMH, right?
Hello, ma'am. I have a question. What is the ideal time to do AMH and FSH? Like which day of?
Yeah, for FSH we know already. For AMH there is no time. Any time of the cycle she can do it, and it varies. It varies also with the cycle, but it varies less. It stays stable most of the time. But this is to tell you the truth. Nowadays they are talking about the variability, that AMH is not that much stable as it was thought before. So it can vary also, and I saw it in reality also. Sometimes we do AMH, and after a few months, then we repeat it and we find it different. So it is also a bit variable, but it is much more stable than FSH. And you don't need to do it in day 2 or day 5. You can do it anytime. But there is a disadvantage, or you call it not a disadvantage. There are pros and cons of everything. AMH is expensive, is much expensive. So you in UK and in NHS you do a thing which is cost effective, right? So if the patient is going for IVF, you can do enteral follicle count, or you can do FSH.
Ma'am, I have a question. For example, there is a patient who is not menstruating every month. Her cycle is not regular. For example, she is amenorrheic for the past 6 months in cases of PCOS. So in that case, we cannot do FSH, which is supposed to be done on day 2 or 3. So which test do you think that is supposed to be done then?
Yeah. So some people do it, they give them withdrawal and then they do the FSH. But there is better thing that we can do. We can go and do the AMH level. It is not affected by the cycle, even if she has cycle or if she has no cycle. So there are different scenarios in which your best way will be different. If a patient is not having any problem, you can go for FSH because it is more cost effective. Whenever a question comes in your EMQ and they ask you, although in the guideline it is written that you can do any one of the following, but they're still asking which one is the best, you go which one is most effective, most cost effective.
But Dr. Samira, it is written in the guideline that if we want to do the most common test, it is FSH only.
FSH,
Most
that
common.
is true. Yeah. So if they are asking about this, because it is written one of the following, you can do it. You have options that you can do one of the following. Yeah. But for the most cost effective is FSH. If you do FSH, you will know. You don't need to do any other thing.
Thank you, ma'am.
So what about the regularity of menstrual cycle? If a woman have 28-day cycle, then it should be day 21 then for the serum progesterone, because it's supposed to be in mid-luteal phase. So what about a woman who has 40 days of cycle, for example?
Just 7 days before her periods, and then continue weekly till
On
she gets the
33rd
reading.
33rd day, 33rd, 33. So they are just giving an example. A woman who has 35-day cycle, it is day 21, 28, 1 week earlier. A woman who has 40-day cycle, it means you will do it on day what?
Day 33.
32. 32.
83, right?
33.
Yeah, 33.
You do it on, you just bring like 1 week minus, just make minus 1 week. Before 1 week, you do them. So whatever is her cycle, whatever, 35 days, 30 days, 40 days, you just do it 1 week earlier. Now, a woman who has irregular cycle should be offered a blood test to measure this FSH and LH. Why? So they are saying that it's a baseline for them. A woman who is having irregular cycle, their baseline is different from a woman who has regular cycle. So you will do it as a baseline. FSH and LH will be done as a baseline if she has irregular cycles. What else you will do as a baseline if a woman has irregular cycle? One more thing you will do.
Serum TSH and prolactin.
Prolactin. So what is the indication of doing prolactin? It is written in the guideline.
Yes, irregular cycles. And if she has any features of
history of galacturia.
Yes, one.
Any
What's the
pituitary
second?
tumors?
Yes, pituitary tumors. Second indication.
Anovulatory bleeding.
Yes, anovulatory bleeding. How you will know she is having anovulatory bleeding? By the sign and symptoms.
Irregular cycles.
Cycles of
Yeah.
Absence
once
of
in 3 to
mixed
4
mass pain.
months.
That is true. Irregular cycles or even amenorrhea. So what are the signs and symptoms of pituitary tumor?
Blood seizure,
field effects
Like
diplopia,
headache,
pressure symptoms,
Headache.
Visual disturbances.
increased
What is
intracranial
Vision
tension.
abnormalities.
the
Increase
sign and
productivity.
symptom?
Headache, blurring of vision.
Headache. Yes, first sign.
Headache.
Not blurring of vision. No.
Field defects.
Yeah. What it is called?
Optic
Bitemporal.
hemi-
Hemianopia.
By the way, there is a talk article about it, isn't it? Subfertility and hyperprolactinemia. There is a whole cut-offs are written over there. So headache, bitemporal hemianopia, and the what else can it, and it can affect even the vision also. And galacturia, exactly. Yeah. So these are the sign and symptoms. Then if she has sign and symptom like this, what you will do? You will ask for the serum prolactin. What is the cutoff for when you will suspect pituitary tumor? And you will ask for the MRI.
More than 200?
200.
500.
200. More than 200.
1,000, ma'am.
200,000 or 500?
200, I think. More than 200.
500.
What is it?
100 nanogram per ml.
Nanogram per ml, right? Thank you for this unit. Because there are two different units and you should know all the units. Whatever the units, there are two kinds of unit for everything and you should know all the units. For prolactin, there are two units. I think one is nanogram per ml and the other one is milligram per ml or something. I don't remember, but there are two units for prolactin, right? And it is given in the talk article.
It is one is international.
And you should know that the value of, what is it?
International unit.
Yeah, mainly international unit, right?
I remember
MIU.
I can't remember.
Yeah, and the other one is nanomoles. Nanomoles per ml and milli international unit per liter. I think so. But you need to check from the, this is another like a brainstorming or you can say as a homework that need to check the cutoffs and the unit, please. I think it is 500. So anything more than 500 to 1000, you will you can suspect, and more than 1000, you have to do it. Of course, if it is more than 1000, you have to ask for the MRI, but even if it is more than 500, you suspect, and also you can ask for the MRI. I think it is written in the TOG article because they are not giving in the TOG article clear cut. It is not written clear cut, but they are giving a lot of studies, you know, like this is the cutoff in the form of studies. That's why some people are confused about the cutoffs. But if it is more than 500, for me, practically speaking, I will ask for the MRI. Okay. So regularity of menstrual cycle. So what about TSH? When you will ask for TSH? Is it a baseline investigation?
It should not be run routinely. Only
ask for
history of
the
irregular cycles.
unless there
Irregular
are
cycles.
symptoms of thyroid.
Symptomatic patient.
Yeah. And what are the symptoms? What are the symptoms?
Like tachycardia, sweating for hyperthyroidism, and the opposite in hypo. So
irregular cycles.
So what is the menstrual irregularity? Hypothyroidism, and what is the menstrual?
Heavy menstruation, heavy menstruation.
Hypomenorrhea.
It can be oligomenorrhea or amenorrhea.
Yes, and in hyperthyroidism,
it can be menorrhagia.
And polymenorrhea.
I think the opposite. It's in hypothyroidism. It's menorrhagia, and in hyper, it's amenorrhea. And
No, it's opposite.
No, in hypothyroidism there is menorrhagia.
I think in this is what I
In
think
hypo and in
hypothyroidism is
hyper, in both. Sometimes hypermenorrhea, sometimes hypomenorrhea. In both.
But what is written in the TOG article, and what I remember is what is written there over there is that in hypomenorrhea, in hypothyroidism, usually it's oligo and amenorrhea. And what is written there in the TOG article in hyperthyroidism is polymenorrhea and menorrhagia. But menorrhagia can happen, as you said, it can be anything, you know, it can happen in both. So that's why they are saying thyroid dysfunction causes menstrual irregularity. But if we are talking about usually speaking, usually these are the symptoms, but any symptom can occur in both spectrum. So we have to check TSH in any menstrual irregularity, which is a sign of thyroid dysfunction. So menstrual irregularity is a sign of thyroid dysfunction. And if some woman will tell you about her menstrual irregularity, then you have to do FSH and LH. You have to do prolactin, and you have to do TSH. This will be as a baseline for them, not for a woman who has regular menstruation. Okay, so what is how you suspect tubal and uterine abnormalities? If the woman has history of PID, she has previous ectopic, she has signs and symptoms of endometriosis. These are the comorbidities, or she has previous surgery, like she has appendicitis or whatever, she has pelvic surgery before or abdominal surgery. So you can predict that maybe she has adhesions, and because of this adhesions, her tube might be blocked, right? But if she is not having any of this, then you can offer HSG to screen for tubal occlusion. Now, talking about tubal occlusion, there is a TOG article about tubal occlusion, isn't it?
Dr. Zaida Akbar, can you please mute your mic? Dr. Zaida Akbar, can you please mute your mic?
Let me see. So what are the tubal factors? Do you know this classification? What is written in the talk article? The classification of pelvic adhesions or tubal occlusion? I think the Rutherford classification. And what you should do, there are 3 types of adhesions. Anyone read this talk article? It's a very old article, but it's not that you have to read only the last 3 years or 5 years. There is no rule. No, there is no rule. Many people are asking me this question. Should we read last 3 years talk? Should we read last 5 years talk?
It depends upon the density of the adhesions, I think.
So the answer is you have to read, even if the talk is 10 years back, you have to read it because you need to find out your answer. You need to complete your syllabus. So if you want to know about tubal occlusion and you don't have any article in the last 5 years, then what you will do? You will read an article which is 10 years back. This is the article. And this is very old article. Tubal disease and assisted reproduction, right? See, tubal disease accounts for, we know the percentage, we know all this. Then what are the options to check for tubal disease? In the guideline, it is written HSG.
Hello, ma'am. There is a lot of echo. Please mute the mic of other.
You know, I have an option saying mute all, to tell you the truth, and it is already clicked. It is muted all, but it means I have to go one by one to see how many
Dr.
people are not.
Dr. Zaida Akbar, her mic is on for last 1 hour.
Second. Some people will leave and then join and leave. Okay, it looks better now. No, it's still.
Is Dr. Zaida Akbar even listening to us?
Maybe not. How can I mute her?
Seems like she has just come to the class and she just left without switching off her microphone.
What is it?
And she must have left her device in her room and she must have gone out somewhere, or else she would have responded.
For sure. But it is coming in with me that I muted for all. So I didn't.
It's Dr. Zaida Akbar, ma'am.
Let me
The
check
computer
how
has
can.
been indicating her name since an hour and a half.
More options. There. Dr. Zahida Akbar is talking right. Yes, you are right. Yeah. I'm not able, she's in front of me. Her name is in front of me. For some reason, I'm not able to mute her. mute her. It's very strange. I can mute anyone.
Otherwise you can mute all the mics, ma'am.
Let me see, mute. Yeah. Oh, okay. Okay. At last. I muted her. Much better. Can you hear me?
Yes, ma'am.
Okay. So, so the tubal disease, there is an article about tubal disease, and they are talking about not only about the hysterosalpingogram, they are talking about HyCO-C also, hysterosalpingo contrast sonography. This one people are not doing it, but HSG, HyCO-C, and laparoscopy. Laparoscopy and dye test, which is called dihydrotubation or simply dye test during laparoscopy. These three things are usually are the options. And before we do this, we can do the to check for the chlamydia. Testing is used like if the patient has this STI or chlamydia infection before, then you can predict that maybe she has adhesions or something. But what these are the three things: HSG, HyCO-C, and laparoscopy and dye test. And what are the options for them? Either you can do expectant management for them, and if the both tubes are blocked, you ask for IVF. You can have option of tubal cannulation and expectant management, doing nothing. Tubal cannulation is the surgery, which is doing hysteroscopically through hysteroscope, and IVF. These are the three options for them, and I will show you a table. So only 3 slides are important in this TOG article. These 3 slides. So what is the Hull and Rutherford classification of tubal damage? Can you see minor grade 1, intermediate grade 2, severe grade 3? And their pregnancy rates are much better in grade 1, which are just there are no fibrosis, and there's no hydrosalpinges, and the tubes are, even if the tube is occluded distally, but there is no hydrosalpinges, and there are flimsy adhesions. This is how it looks like. Okay, here. So this is grade 1. So in grade 2, there is unilateral severe. One tube is totally damaged, and the other one is maybe minor damage or no damage. There are limited dense adhesions, and the pregnancy rate, of course, is less, and the risk of ectopic is high. In grade 3, there is bilateral tubal damage, and there is hydrosalpinges. What is the cutoff? Now, from this statement, we learn from each and everything, right? From this cutoff, tubal distension more than 1.5 centimeter. It means if there is any hydrosalpinges more than 1.5 centimeter, it is significant. We get our cutoff from this statement. And there is bipolar occlusions, and there are dense adhesions. So this is grade 3. There are 3 grades written in this TOG article. This is the TOG article. And what is the solution? Management. So if there is a tubal disease and she is less than 40 years of age and more than 3 years of infertility, then you have to see if it's a tubal proximal obstruction. If there is a proximal obstruction in HSD, you can go and do the tubal cannulation through hysteroscopy. And if the tube remains occluded, then you consider of microtubal surgery, which can be done laparoscopically. Or there is another solution. You can wait for 1 year. If within 1 year you go for IVF. So you do if proximal obstruction, you can for sure go for IVF, but you can offer her tubal cannulation. And if within 1 year she will not get pregnant, you go and do the IVF. What is the selection criteria? You have to check the age, which is written here. The duration of infertility should be less than 3 years. Should be less than 3 years for this option. No other coexisting, maybe the male is having azoospermia, so what's the point? So no other coexisting fertility factor, no previous ectopic, because if it is ectopic and you are going to do the surgery, then there is higher chance of repeat ectopic again. That's why. So you fulfill the criteria, selection criteria, and you go and do the surgery. If it's a distal blockage and you find that the distal severe or bilateral or bipolar. Bipolar means there is a difference between bilateral and bipolar. Bipolar means proximal blockage and distal, all the tube is blocked from proximal to distal. And bilateral is bilateral, right and left. So if it is something like this, you have to see if there is a hydrosalpinges, no hydrosalpinges. Hydrosalpinges, the best is salpingectomy. No hydrosalpinges, go for IVF. So if it is hydrosalpinges, you do salpingectomy and then you go for IVF. So this is a beautiful table. It's not a new TOG article, and I don't know if how many people have read it, but I just like it a lot.
Ma'am, how about unilateral hydrosalpinges? If it is there, so should we remove?
It is not written that hydrosalpinges should be bilateral to be removed, isn't it? So even if you find unilateral hydrosalpinge, what is the problem with, let's talk about hydrosalpinges. What is the problem in hydrosalpinges? What it is doing? Some people are
Release
giving
of toxins, that is embryo toxic.
Yeah, it is embryo toxic. It means it impairs implantation. It washes away the embryo. It inhibits implantation. The success rate becomes 50% low. If you have, you can, the question is, can you do IVF? If she has tubal block, if she has bilateral tubal block, you want to do IVF, and there is a unilateral hydrosalpinges, which is significant, more than 1.5 centimeter. You will do IVF for her, or you will say, no, I will not do IVF, and you have to do salpingectomy. What is the answer?
Salpingectomy has to be done first. But salpingectomy has to be done if it is more than 1.5 centimeters dilatation. But the question is, if she has a hydrosalpinges on one side only and the other tube is normal and she's going for IVF, do we need to do salpingectomy both sides or one side is enough?
Yeah, this is the question. Okay. So I will answer this question, and then there is another question which we will talk about it after this. So she's going for IVF for other reason, maybe the male factor, right? And you find that tubes are open, but there is a hydrosalpinges on one side, unilateral. And if it is significant, it is more than 1.5 centimeter, then you counsel her that better to go for salpingectomy. Why? Because either this side, the toxins are coming from one tube, or the toxins are coming from both tube. What is the difference? The toxins are there and they are coming to the uterus and they are impairing the implantation. So even if it is unilateral and it is significant, especially more than 1.5 centimeter, you will offer her salpingectomy before going for IVF. Now there is a TOG article about the surgeries which needs to be done pre-IVF. Have you read this article?
For both the sides, ma'am?
Hmm?
Salpingectomy for both the sides or only unilateral?
You know, if you go and you do the salpingectomy, you never do it on one side. Yeah, because she's going for IVF anyway. She does not need the tubes, because if hydrosalpinges develop in one side, it can develop in other side also. So there is a possibility. The answer is yes and the answer is no. It depends upon the patient. You have to counsel the patient. and you have to tell her that you are going for IVF for whatever reason, and both tubes you are going to occlude it, but it's her choice. If hydrosalpinx is on one side, you can go and do the salpingectomy once. And if you think that she has option of having a without IVF, she can become pregnant. Maybe she has something that some other factor. Maybe she has PCO, and because of this, you are doing IVF, and she has chance of becoming normal pregnancy later on, right? Without IVF, so you will not do the bilateral salpingectomy. So it depends upon the scenario. So in exam, they will give you a scenario. For example, even if the male factor infertility, for example, the husband is azoospermic, and both her tubes are patent, but one tube is hydrosalpinx and it is more than 1.5 centimeter. You will say that yes, you will offer her salpingectomy, but the question is either unilateral or bilateral, because anyway she does not need her tubes. She's going for IVF because her husband is azoospermic. So the answer is from this husband, yes, she might not going to have a baby, but she can have from her another next husband. So the answer is, if she has chance that she can use her tube, the other tube. So you do it laparoscopically, you will see if her other tube looks normal, you can leave the other tube. No need to do it on the other side. If she has chance that she can do it without IVF, she can get pregnant without IVF, you will leave the tube and you will go and do one unilateral only. So this is the answer.
Ma'am, related to this table, I have a question that immediately after the diagnosis, we are going towards the surgery. We are not doing any investigation, for example, hycosi or lap and dye or hysterosalpingography. When and why are we going to do those investigations?
You mean before salpingectomy?
Related to the table, madam, this table that you have been telling, in which there is mild, moderate, and severe tubal disease, we are immediately going towards the surgical or other procedures. We are not investigating the disease. So why are we not doing that? And when are we going to do the investigations?
Okay, so once we recognize that there is it's a holistic approach for every case and every patient. If you find HSG, you have done HSG, for example, and you find that there is a hydrosalpinx or there is a tubal obstruction, you go and do the all investigations of infertility. You will need all investigations which are baseline for infertility, right? And also there is one more question arises from this. If one HSG shows that she has a tubal blockage, are you going to confirm it, or you go and do the IVF for her?
We are going to
We should
confirm it.
confirm it first, ma'am.
Yes, the answer is yes. You should confirm it first. So how you confirm it? What are the options to confirm?
Histolaparoscopy.
Yes, because you can do laparoscopy dye test.
Yes, ma'am.
It is invasive. But if the patient refuses for any invasive, is there any other option?
Hiscoe, ma'am.
Yeah, hycosi you can do. You know the procedure of hycosi, right? Saline sonohysterogram.
Yes, ma'am.
Yeah. So there are three options that you can do. So the answers depend upon the scenario. For all patients who are going for infertility, you have to do all the investigations for infertility. And then you select your patient. She can go for surgery, but before this she has to do, maybe her husband or partner, sorry, you cannot say husband in UK, you have to say partner. So her partner might be azoospermic, for example. So you have to do all the investigations. Or maybe she is having premature ovarian failure or whatever, I mean. So of course you have to do all the baseline investigations, and what are the investigations needed for pre-surgical investigations, anesthesia, everything. And then she can go for the surgery. Surgery can be tubal cannulation if it's a proximal obstruction, for which the success rate is very less. I have not seen any patient which goes for tubal cannulation and she has proximal obstruction. She go for tubal cannulation and then she become pregnant. Ultimately, they will need IVF. But if she is more than 3 years of infertility and she has tubal disease, you see, you have to check this right box. Look at the right box. She is less than 40 years, more than 3 years of infertility and tubal disease. Look at the arrow, directly IVF. So you will not select her for surgery. It's directly IVF. The facts about hydrosalpinx.
Hello. Hello. Hello.
Hello.
Ma'am, if you can hear us, we cannot hear you.
Yes.
You're stuck. Your voice is not coming.
My connection was lost for a few seconds. Sorry for this.
Okay.
I stopped my video.
Not a problem. Not a problem.
Yeah. So we were discussing about this hydrosalpinx, and there's a talk article regarding this. What you do? What we were discussing at the last movement, and this is all surgeries you have to do. Yeah. My question was, sorry. My question was, if the patient do not want salpingectomy, what is the other option?
Clipping of tubes by
Yes.
hysteroscopy.
Yes, laparoscopic
Tubal
clipping
ovulation.
at the corneal site, laparoscopic clipping. So you clip, if she has bilateral hydrosalpinx, you clip both. You clip both. Is this clipping is reversible?
Yes.
Yes, ma'am.
The answer is yes, but salpingectomy is not reversible. Okay, here we go. If you don't find any information from your talk article, from your guideline, you open your strategy, because it's always updated. The strategy is updated always. So, I just want to show you that how this guideline is opening a door for a discussion. So there is something about everything in this guideline. So once you talk about poor ovarian reserve, then you open the subject of AMH, premature ovarian failure, the causes of premature ovarian failure. Now, what is the definition of premature ovarian failure, by the way? Because we missed that part. Can anyone tell me definition of premature ovarian failure?
Loss of ovarian function before 45 years of age.
Now, there is a TOG article and the definition is written.
40 years.
Premature
Before
ovarian.
40 years.
Yeah, in a woman who is less than 40 years, then what is the cutoff of FSH in order to say
30, ma'am.
More
It
than
should be more
30.
than 30.
25 for
35,
in
35. It should be
25.
35 or more in 2 occasions.
Yeah, on 2 occasions. How many weeks apart?
12 weeks.
4 to 6 weeks.
4 to 6 weeks apart.
4 to 6 weeks apart.
Okay.
But I have a question, ma'am. It was written in somewhere, I honestly can't remember, 30, and in another part it was written 40. So I don't know the cutoff level of the FSH. Is it 30 or 40? I don't know.
Let me open this. I have very nice presentation. So there is a TOG article. You know this TOG article, right? 2011. Diagnosis and management of premature ovarian failure. What is the percentage? It is 1 in 100 women before 40 years. And 90% are idiopathic and the rest are autoimmune chromosomal. It can resume. Any patient who has premature ovarian failure, their ovarian activity can resume in 5 to 10%. Okay. What is the definition? Okay, premature ovarian failure. This is the definition. Before 40 years, it is considered premature and is known as premature ovarian failure. A widely used definition is 4 months of amenorrhea and 2 FSH levels, 30 international unit per ml. You always have to remember the units because sometimes there are 2 kinds of units used. So if the FSH levels 30 international unit per ml, 4 months of amenorrhea, 2 FSH of 30 international unit per ml, and interval of at least 4 weeks or 1 month. This is the definition of premature ovarian failure, and it is written in the TOG article. And there are many causes. As it is written, it is 90% idiopathic. There can be chromosomal abnormality like Turner and others, gonadal dysgenesis, iatrogenic causes, autoimmune causes. Okay. They can be fragile X syndrome. It is, you have to take the history from the patient, you know. I'm just showing you that how much information is there in one TOG article. What are the baseline investigations that you need to do if you find that premature ovarian failure? First of all, 4 months of amenorrhea, you need to rule out the pregnancy, right? And then you have to do the serum prolactin and thyroxine level to rule out hyperprolactinemia and thyroid dysfunction. It is not written hypothyroidism, it is written thyroid dysfunction. As you said, sir, that maybe amenorrhea can be because of anything. So you have to just check the TSH and rule out hyperprolactinemia. Serum FSH, LH, and estradiol levels are equally necessary. Okay. So if there are signs of hyperandrogenism, then you have to check for serum testosterone level and dehydroepiandrosterone. So these are the baseline tests, okay? The follow-up test, according to the result of baseline test. So if there is FSH, high FSH, LH, it should be repeated, you can say after 4 weeks. And if it's persistently raised, then you confirm premature ovarian failure. You can do the ultrasound of the pelvis to check the endometrial thickness. Why you want to check endometrial thickness? Because it will show you the estrogen status, ovarian volume, and antral follicle count. Are you going to do progesterone withdrawal test for patient who has premature ovarian failure to evaluate estrogen status? The answer is, I will do it, but it is written in the TOG article with less clinical significance. You know why? Now, if any patient who has 4 months of amenorrhea, she's not pregnant, what immediately you will do if you want to evaluate her estrogen status? What is the best test to be done? Is it a withdrawal test or is it an ultrasound and endometrial thickness or the E2 level, estradiol level?
ET under ultrasound.
You can have an idea from the ultrasound, but you can do the estradiol level as well, because this is in the form of ultrasound, and that is laboratory test. Because 20% of women who have amenorrhea can have withdrawal bleeding. Primary amenorrhea will have withdrawal bleeding, even if they're 50% of women with secondary amenorrhea and 20% with primary amenorrhea will have withdrawal. So if you will give them progesterone, they can have withdrawal bleeding, 50% of them. And this will give a woman sense of reassurance, and this might be misleading, although her estrogen is low, but she will have withdrawal. So it is better to do the ultrasound and the estradiol level if we want to check her estrogen status. Now, if it is confirmed, the second line investigation is you want to know the cause. Is it due to the Turner X0 karyotyping, or this FMR premutation? And there is a separate talk article about FMR premutation, isn't it? Familial, it stands for what is the name? I'm forgetting it. Familial what? FMR.
Mental retardation.
Yeah. FMR. Premutation, yeah. So there's a talk article about it anyway, because it causes premature ovarian failure. And autoimmune diseases, you can test for anti-thyroid peroxidase, anti-thyroglobulin antibodies, anti-21 hydroxylase, ovarian antibody screening. Beside providers, these are the second line investigation. Okay, before providing a clear explanation as to the cause, so you are checking the cause of her POF, right? And she might have high risk of autoimmune condition. You can do other tests like AMH, but ovarian biopsy is not recommended, to tell you the truth, but you have to do DEXA. DEXA is dual emission X-ray absorptiometry. It's a baseline assessment. As women with premature ovarian failure, they are high risk for having osteopenia, almost 50% risk. So you have to do DEXA once you confirm that she has premature ovarian failure. So karyotyping, screen for autoimmune, AMH, ovarian biopsy, no, but DEXA, yes. So what is the management? Can anyone tell me, if a patient comes to you, you confirm that she has premature ovarian failure and she wants to get pregnant, what are her choices?
Donor oocyte.
Yes.
Oocyte donation.
Yes.
Donor oocyte and also adoption.
Good. Is there any other option?
You can conceive by
Surrogacy, spontaneous pregnancy.
So she has to wait for spontaneous pregnancy?
They start
IVF, ovarian stimulation.
Surrogacy. Can you do IVF for her? Premature ovarian failure. FSH.
I think donor oocyte.
Yeah, for sure. But she want from her own genetic child. Is there any option?
There are 8% chances of spontaneous conception.
Yeah, she is 40 years old. She doesn't want to wait for spontaneous conception. So in this case, what is her option?
Oocyte preservation. Oocyte preservation.
Why her uterus is fine? Why she will need surrogacy?
She have a uterus.
Ovarian stimulation.
Let us see what is written in the guideline. Now, HRT.
Ovarian donation.
Let's see. I will show you something very interesting.
Ovarian tissue reimplantation.
Yeah, there are options written here, they are talking. Okay. Here, I think. So for those who decide parenthood, the options include either adoption, as you said, or achieving a pregnancy by embryo or oocyte donation. Okay. And this can be in oocyte donation, it is necessary to prepare the endometrium for implantation because she has no estrogen is low, right? So you can give her estradiol valerate from 2 to 6 milligram over a 2-week period so that you prepare her endometrium for implantation. And then progesterone therapy, which is started 400 milligram twice daily. It will create endometrium for embryo implantation. This is the way of doing with embryo donation. You are preparing the endometrium for implantation and then embryo donation or oocyte donation. Now, women diagnosed with cancers, what they will do then? They can preserve, right? As you said, they can go through it with gonadal shielding or ovarian transposition, or you can do ovarian suppression while you're giving chemotherapy so that the ovarian tissue is preserved. This is their option. Now there is one more thing written here. Another treatment option. I want you to concentrate here. Another treatment option. Okay. Another treatment option that provides some hope for women with premature ovarian failure is estrogen suppression followed by exogenous gonadotrophins. So whatever the estrogen is there, so you are doing like, so it's like, you know, you are giving exogenous gonadotrophins to her. Because the problem with them, they are having high FSH. With POF, they are having high FSH. So you have to suppress this FSH. So in order to suppress this FSH, you give estrogen, right? And then when this FSH is suppressed, you start giving her gonadotrophins. Now, pre-treatment with estrogen suppresses the FSH and allows restoration of FSH receptors in the remaining follicles. When this pre-treatment was followed by gonadotrophin stimulation, ovulation occurred in 32% of cases, and among them, pregnancy can be achieved in 50%. Now, I want some of you to summarize what you understand from it.
That there are 3 methods of conception in the case of ovarian failure. There are 2, which includes adoption and oocyte. And there is a third option, which includes that the estrogen should be suppressed in that woman because she's having increased estrogen. And by after priming her uterus with that, we are going to give her external gonadotrophins, which are going to improve the fertility from the remaining ovaries.
One second. You need to suppress FSH by giving her estrogen. I want to correct you so that you will not remember something wrong. Yeah, then after that, you're right.
Okay, we get it.
And in this, ovulation can occur in 32% of cases. So this option is never offered to any woman ever, but it is written in the talk article and it is there.
Is it such, ma'am? Ma'am, is it, ma'am, please repeat once again, ma'am.
Yes. So what are the options for?
Is it estrogen suppression or gonadotrophin suppression, ma'am?
It is FSH suppression, because what is the problem in premature ovarian failure? FSH is high, right? Because follicles are very less and they are not producing low estrogen, high FSH. This is the problem, high FSH, right? So you need to suppress this high FSH by giving her estrogen.
Makes sense.
Okay, ma'am. Okay, ma'am.
Yeah, and once the estrogen and once the FSH is suppressed, you will do the test, right? And once the FSH is suppressed, then you give her controlled gonadotrophins, like in IVF tree. You are giving controlled gonadotrophins.
Yeah, actually in the talk article, ma'am, it is written here, what you are showing the slide, it is showing that estrogen suppression is done. So actually it is gonadotrophin suppression of the
FSH is not being
gonadotrophin.
suppressed. estrogen is being suppressed. This is what is written here.
You know, I want you to concentrate on this line, this one. Pre-treatment with estrogen suppresses FSH serum levels. This is they are explaining what they mean, and allows the restoration of FSH follicles in the remaining follicles. Maybe some people can misunderstand from the statement below, but the statement down is very clear. So they are giving pre-treatment with estrogen and it suppresses FSH. Because estrogen is not high, why you want to suppress it? Estrogen is low in POF. The FSH is high, so you need to suppress FSH. You get my point?
Yes. Well, yes, here your
Yes,
point
ma'am.
is
Now
confirmed,
it's
but
clear.
the other point, which is another treatment options, the one that was given there, it was a misleading one, but now it's clear.
Yeah. Maybe because you know, maybe this is how we perceive. They are sometimes writing something, but it depends on the individual how we are perceiving. Sometimes in the guideline also, different people perceive things from their own perspective, which might not be what they want. It can happen. There is one last slide which I want to show you in the TOG article because this is summary of this TOG article. So AMH is produced by the granulosa cells of early developing follicles and is thought to be an early marker of ovarian aging. An association has been confirmed between AMH and the number of oocytes recovered in IVF cycle and IVF success rate. AMH is proving a reasonable predictor of ovarian reserve. Okay, but it is costly. Very low AMH are critical signals of diminution in the available follicular pool and reflect the minimum capacity to recruit. So what is the difference between, you see, AMH starts declining 5 years before final menstruation period. So you can never know actually exactly that if AMH is low, your patient will ask when I'm going to have 0 follicles. So you can say anywhere between 5 years, 1 to maybe after 6 months, you never know. It depends upon her level also, you can give an idea. If it is only 1 or it is less than 1, you can say that soon. Soon, how soon? There is no answer for AMH. This is the problem. There is no answer how soon, but within 5 years. You see, this is the TOG article 2012 for AMH. Okay. The good thing about AMH is shows less intracycle and intercycle variation. And there is an important advantage of AMH over FSH as it can be reliably measured at any stage of the menstrual. So it's not between day 2 to day 5. So this is an advantage. The problem is it's very costly. And NHS want cost-effective things. Long-term use of oral contraceptives and analog can reduce AMH. If the patient is on OCP for a long time, maybe, and if you will check her AMH, you'll find it reduced. False negative, right? It will be falsely shown. These studies confirm the presence of ovarian activity independent of, okay, let's see. Decreased AMH are indicative of reduced antral follicle pool and ovarian reserve independent of age. You might find a young girl, 25, 30 years old. I have seen many girls like this with AMH less than 1 and some of them less than 0.5. It's 0.2, 0.3, you know. So it is independent of age. High AMH is suggestive of polycystic ovaries. You see the same thing as it is written in the antral follicle count of less than a total of 4 from both ovaries. And you know what is written in the ovarian volume? Less than 3 centimeter. If it is less than 3 centimeter. In PCO, what is the cutoff? What is the volume?
10.
Which you can say that
10.
10 cc.
10 cc, ma'am.
Yeah, it is 10 cc or 10 ml. Now I want to ask you, because we are talking about PCO here. Yeah, oh, you see the range 0.1 to 1.4. That's why I'm thinking that it's the cutoff. It is written in the talk article. This is what I was thinking, that I remember 1.5. So here it is. It is written in the talk article. And this is the unit.
Token
So
is what?
So it is between 0.1 to 1.4 is a cutoff for predicting a poor response to ovarian stimulation. So the question is, if the patient has so anything it
There is a lot of background noise, ma'am. We can't hear you.
yeah, again I have to check. Oh, it's okay now.
Yes,
Can you hear
yes.
now? It's better. You know, I learned it today that you can adjust your setting, because a person is learning every day, right? If someone is, so it is showing me now only the person whose mic is on now, so I can right away go and don't have to look for the others. I just learned it today, so it is very good for me. Whoever mic is open, I will know immediately. It will not happen again. So the values ranging between 0.1 to 1.4 is a predictor of poor ovarian stimulation. The question is, if anyone has less than 1.5, can she go for IVF, or you will deny her?
She can go, but we have to tell her that there is a chance for the.
That is fine. She can go for IVF, but you
She
have
will
to
have
counsel.
she
She will have
low
poor
response.
response.
She will have poor response. I have done many IVFs for less than 1.5, but the success rate is really poor, you know. But some people, they want to take chance, right? So we cannot say no to anyone. Is there an age limit for IVF?
Yeah.
Yes,
Before
Our
cutoff is
40,
40. Cutoff is 42. 42.
And 40 to 42, one cycle.
Up to 44.
Up to 42.
So if you got a patient for I'm sure that there are many people who are sitting in fertility clinics. If a patient comes to you, she's 48 years old. Her FSH is 7. She has 6 follicles in each ovary, 5 to 6, 4 to 5, 6 to 7, something like that. Semen analysis for her partner is normal. Everything else is okay. Tubes are patent. You will deny her that because you are 48, I'm not going to do IVF for you?
No, she can have a right of conception, but she can, NHS will not afford. She will do
Yes,
privately.
this is the answer. So whatever is written in the guideline is the NHS criteria. It is the NHS criteria, right? But she can go and have her IVF in private. She has right. You just need to find out that all her investigations are fine. And you need to counsel her about the problems in pregnancy that she can have because of her age. That's it. If she wants to try, you are not going to deny her. I have 2 patients right now, 48 and 49 years old. One already delivered with triplets, and the other one is pregnant by 8 or 9 months. I think she entered 9 months pregnancy. But her
Hello, ma'am.
investigations
It
were
means
normal.
hello.
Yes.
It means, ma'am, NHS will fund it for till 42 years after onwards. They will go for private, isn't it?
That's true. NHS is funding up to 42 years only. And I will show you the criteria that, if it is she's less than 37 years, she's 37 to 40 years, and if she is between, they divide the patient, the treatment that she will receive according, and the embryos, single embryo, double embryo, according to the age, right? It is written in the guideline. But up to 42 years, they are accepting. They are accepting the NHS. We are talking about NHS. Okay. Early ovarian aging, low ovarian reserve at a young age, early 30s. There is a TOG article about it, 2019. There can be many causes: genetic factors, infection, autoimmunity, smoking, drugs, chemotherapy, radiotherapy. I have seen many girls in their 30s. I have seen even in 25 years of age, they are having very low ovarian reserve. So if the FSH is more than 15, there is a reduction in fecundity rate of up to 50%, right? And they have more aneuploidies and miscarriage. The problem is quantity. But in younger women, if she's younger, the quality is preserved. The problem is quantity. But there is increased risk of aneuploidy and miscarriage. Anyway, so management. What is the management? IVF is the most commonly employed treatment strategy. Yes, they can have IVF. But the problem is, the reality is, many fertility clinics may not treat women with extremely poor ovarian reserve because they will drop their success rate. For example, I'm having 5 IVFs in a month. 3 of them are having poor ovarian reserve, and I accept them. And all 3 of, because their success rate is very high, right? Live birth rate is very high. So it will reduce my, if someone will do audit, it will reduce my success rate, right? This is the problem, that it's going to affect my success rate. However, data shows significantly better IVF outcomes in young women with early ovarian aging than in older women. Data from 2017 suggests live birth rate of 17 to 29% in women. So if she has poor ovarian reserve or early ovarian aging, her FSH is more than 15, which is not normal, of course, and she's younger than 35 years old with low ovarian reserve, she can have live birth rate of 17 to 29%. They are talking about live birth rate because they just said that they have increased incidence of what you call it, miscarriages, right? That's why they're talking about live birth rate. So in this talk article, they talk about, there are 2 modalities for premature ovarian, poor ovarian reserve. We are not talking about premature ovarian failure. Premature ovarian failure by definition is FSH 30 or more. We are talking about poor ovarian reserve, right? And for poor ovarian reserve, now we are not talking about premature ovarian failure and the 3 treatment options for them. We are talking about poor ovarian reserve. For poor ovarian reserve, like FSH 15 or more, for example, because we know the normal. Anything from 9 and above, it means poor ovarian reserve. So what they are giving dihydroepiandrosterone. There is a meta-analysis and it shows a benefit with increased clinical pregnancy rate, live birth rate, and reduced miscarriage rate. There are data to suggest that this effect is age-related and younger women will benefit more than older women. There is a lack of high-quality RCTs, but the problem is high-quality RCTs, there is a lack. So in some studies, it shows benefit, and meta-analysis also shows benefit. But the RCTs, there are RCTs, but not high-quality RCTs. But what you will do, even if there is no high-quality RCT and the meta-analysis shows benefit, are you going to give them or not? You want to do IVF for poor ovarian reserve. She's a younger woman, 30s, early 30s, and you accept her and you will do IVF for her. You will give her dihydroepiandrosterone or
I can't hear you because there's too much background noise.
So I'm going to give dihydroepiandrosterone.
1 second, I will mute again. Now I will lose my concentration like this if I will go on muting again and again. Okay, it's muted now. So my question, a woman with poor ovarian, so a scenario, 32 years old, her FSH is 16, say 16, 18, whatever, 19, more than 15. And you accept her that you will do IVF for her. Okay. So are you going to give her dihydroepiandrosterone? As it is written in the TOG article, this treatment is written in the TOG article. Dihydroepiandrosterone. DHEA. Are you going to give her?
Yes.
Yes.
We'll go
So
according
we
to
can discuss with the patient, and if she's giving, we can.
Yes. For anything which is not in the guideline, you have to discuss with the woman because it needs consent. But there is no harm in giving. So for me, I will give because there is no harm in giving. So you can give. Okay. But you will tell her that there is no high quality RCTs. There is some proof that it's beneficial. And also there is a meta-analysis which shows that it is beneficial. So at present, most women with early ovarian aging are diagnosed late, such as FSH value of 10 to 20 and antral follicle count below 4 and AMH below 5 pentamoles in women younger than 37 years old. They are just defining. Depending on individual circumstances, fertility treatment options are for them is egg freezing, embryo freezing, or treatment with donor sperm for single women. So you just go and freeze their eggs, and if she has a partner, you can freeze the embryo. If she's going to have, she is very young girl, 25 years, 28, 29 years old, you find that she's going to have premature ovarian failure, you can go and do the egg freezing or embryo freezing. Future treatments are aiming to slow the ovarian aging or restore the... Okay, there is one more interesting thing. Pharmacological methods of reducing the rate of follicular decline, use of antioxidant coenzyme Q and resveratrol. So there are three things: dihydroepiandrosterone, coenzyme Q10, and resveratrol. They are antioxidants. And in practice, you will find hundreds of drug companies, pharmacological companies, they're coming and giving you a combination of DHEA, coenzyme Q, and resveratrol, and a combination of antioxidants. Anyway, but these three things are mentioned in the TOG article. But what they are saying, future treatments and pharmacological methods of reducing are being sought. So it's something like in research, right? But for DHA, they are saying that there is some benefit shown, although there is no high quality RCT, but there is a meta-analysis. So you can give. There is no harm in giving coenzyme Q10 and even resveratrol. The only thing is it's costly, but there is no harm. But the patient will accept it. This is my, just wanted to show you my presentation about premature ovarian failure and the TOG articles related with it. Okay, because we have to finish this one. So any patient who is going for IVF, you have to do the HIV, hepatitis B and C. It's not a baseline test for infertility. It is not. But if the patient is going for IVF, you have to do this test. Now let's talk about the HIV. For couples where the man is HIV positive, it depends on three things. Advise couple where the man is HIV positive that the risk of HIV is negligible through unprotected sexual intercourse if they met the following criteria. The man is compliant with heart and plasma viral load is less than 50 copies per ml for more than 6 months. Unprotected intercourse is limited to the time of ovulation, then he can have unprotected sexual intercourse if he fulfills the criteria. And advise couples that if all the criteria is met, sperm washing is not recommended because it will reduce the likelihood. Sperm washing, by the way, it decreases the success rate. It reduces the likelihood of pregnancy. For couples where the man is HIV positive, he is not compliant with heart, his plasma viral load is 50 copies or greater, then you can offer sperm washing. Sperm washing reduces the risk of HIV transmission, but it's not going to eliminate it. This is one thing about HIV. If couples who meet all the criteria still perceive an unacceptable risk of HIV, they perceive, this is their perception, right? They are saying no, even if the risk of transmission is there, then you can say, okay, you can go and do the sperm washing. Inform couples that there is insufficient evidence to recommend that HIV negative women use Pepsi. You know Pepsi? Pre-exposure prophylaxis when all the criteria is met. If the woman is HIV and the man is HIV positive, she is HIV negative. If all the criteria is met, man is on heart medication for more than 6 months, his copies viral load is less than 50. These three criteria, right? So, and they are doing intercourse only at the time of ovulation. So there is no need for woman who is HIV negative to use Pepsi, which is the prophylaxis. What about hepatitis B? Offer vaccination before starting fertility treatment and nothing else. And no need to do sperm washing for hepatitis B. What about hepatitis C? If the man is hepatitis C, you need to send her to hepatitis specialist and fertility specialist. The risk of transmission is low, but it is there. And men with hepatitis C should discuss the treatment options so they can go and see the hepatitis specialist to eradicate hepatitis C because there is a treatment for it. Now, susceptibility to rubella. Women who are susceptible to rubella should be offered vaccination, MMR. And after MMR, she should wait 1 month before getting pregnant or before trying to get pregnant. So cervical cancer screening, if she is due for cervical cancer screening, you go and do it. Screening for chlamydia, it is only before uterine instrumentation. offer her screening for chlamydia. And if the result of chlamydia is positive, you have to send her to gum clinics, right, for contact tracing and treatment of this chlamydia. And if the result is not there, or if the screening is not carried out, or if the result is not there and you want to do uterine instrumentation, you can give her prophylactic antibiotics. Now, what about male factor? There is a whole talk article about male factor infertility. So what is the medical management for male factor infertility? Let's talk about this. Medical management. Men with hypogonadotrophic hypogonadism should be offered gonadotrophin drugs because these are effective in improving. So for like female, even if the female is having hypogonadotrophic hypogonadism, you are offering her gonadotrophins, both FSH and LH. It's the same like men also, because they have problem from pituitary from above, right? Men with idiopathic semen abnormalities, and you don't know the reason why he has these semen abnormalities. So are you going to give her like anti-estrogens? Are you going to give him gonadotrophins? You will give him androgens. It's not showing to be effective. It's idiopathic. So what you will give him? Any suggestion? You don't know. He has semen abnormalities, motility is low, morphology is little bit 2% low, count is mildly low, and he's not using any kind of medication. His occupation is he's not obese, not smoking, idiopathic.
Sperm retrieval.
So what you will give him? Are you going to give him something?
I will refer her to.
Yes.
We will investigate also.
Exactly. You are going to refer him for sure. But what do you think the urologist or andrologist are usually giving them?
Antioxidants.
They can
There are many things they are giving, like vitamins, vitamin E, zinc, many things, like some kind of multivitamins with vitamin E and zinc in it. And some people are even giving them antioxidants, but it is not written in here. It is just written in the talk article. Don't give them all these gonadotrophins and androgens and bromocriptine, but they do not mention anything about antioxidants and multivitamins. But of course you can give this, no harm in giving. Surgical management, male factor infertility. Obstructive, there are two kinds of azoospermia, obstructive and non-obstructive. If it is obstructive azoospermia, then you can offer, although you are going to refer the male to urologist, but you should know, you should have an idea what urologist is going to do, because you are the one, the couple is sitting in front of you, you need to counsel them. So if a man is found to have obstructive azoospermia, he can have surgical correction of epididymal blockage, because you are going to send him to urologist. He will do all the hormonal test, ultrasound, scrotum, and then they end the examination and they find out that he has epididymal blockage. So what you can do this, you can offer surgical correction, because it is likely to restore the patency of the duct and improve the fertility. Surgical correction should be considered as an alternative to surgical sperm. And what is the other option? The first option is epididymal blockage if there is epididymal surgery or reopening if there is a blockage. The other is just surgical sperm. And the third option is IVF. I have to leave for a few seconds because there is someone at the door. Let me see. Just Or you can all have a 5 minutes break, because we need to drink water. Just 5 minutes.
That would be awesome.
Thank you.
नहीं हो रहा है बस ऐसी कोई बात नहीं
Hello. Hello.
Hello.
There is no sound, no?
Break 5 minutes.
Yeah, hello. Okay, let us start. So related to male factor infertility, we talked about medical, we talked about surgical correction. So if so I have a question because there is a talk article about male factor infertility. There are two kinds of obstruction, obstructive azoospermia and non-obstructive azoospermia. So what can be the reason of obstructive azoospermia? Possible causes. So the tubes are blocked, right? Maybe the epididymis is blocked.
Cystic fibrosis.
Yes. What happened in cystic fibrosis? What is the name of the tube that is blocked or that is not congenitally present?
Vast difference.
Vast difference.
Yeah, congenital absence of valve. This is in cystic fibrosis. It is obstructive azoospermia. What else can cause obstructive azoospermia? Any kind of infection?
Yes, epididymitis, orchitis.
Orchites.
Orchitis. And what kind of infection?
Mumps. Early
Yeah.
childhood mumps that can lead to orchites.
That's true. Even tuberculosis and sexually transmitted infections can cause the tubal blockage, like females. So we can do surgical correction. And what is the, okay, so what is the other alternative?
Donor or sperm retrieval?
Sperm recovery. Surgical sperm recovery. From where?
From the epididymis.
Epididymis?
Either you get it from epididymis or you can, even if you don't find it in the tube, you can find it in the testis itself. It's called testicular pouch.
It is for non-obstructive, right?
Yeah. In non-obstructive, usually in non-obstructive, you are right. So what can be the causes of non-obstructive azoospermia?
Abnormal karyotyping, Klinefelter syndrome.
Yes.
Testicular and the pre-testicular, like
hypothalamic.
Hypothalamic, like Kalman syndrome, Charge syndrome, and another one.
Young syndrome.
Yes.
No,
That is for cystic fibrosis.
Young is same like Turner in female, isn't it? If I'm not mistaken.
No, that's Noonan syndrome. Noonan syndrome is same as Turner.
No syndrome, like Klinefelter, it's a testicular cause.
So
okay,
it's written in the talk article.
It is equivalent to Turner in
but
male.
the hypothalamic is
it is Noonan and Turner.
No, Noonan like Klinefelter, testicular.
No, Noonan is written in the talk article that it's similar to the Turner. 45XO, that's Noonan.
Yeah.
Yes, you are right. So yes, this might be the cause, testicular hypothalamic cause, yes. And genetic cause, chromosomal. There is any chromosomal cause?
Yes,
yes, long Y
cystic
microdeletions.
Yes. Y microdeletions, okay.
Long arm.
Long arm. Okay. Because we are talking about male, there can be ejaculatory failure, retrograde ejaculation. What is the treatment of retrograde ejaculation?
Surgical.
From the post ejaculation, we can find the sperms from the urine.
Yes.
And ICSI.
Okay, this is one of. There is any medical treatment?
Yes,
Is it some receptor agonist? Alpha, beta?
Sildenafil.
It's alpha receptor.
Yeah, it's alpha receptor agonist, right? I don't know exactly the name of the medication, but the generic is at the level of the, you can say that the receptor is alpha agonist.
It's finasteride, flutamide, something, I guess, in between the two of them.
Where it is written?
The alpha one something.
alpha reductase inhibitors.
It's alpha reductase inhibitor, but where is exactly you find this the name of it? Is it in that strategy or what?
I exactly cannot locate, ma'am, but I've read it somewhere. I recall when you're asking, so I'm recalling it, but exactly I don't even myself recall where I read it.
Yeah, I read it somewhere also, but I'm the same. I cannot tell you exactly from where I read. But there's
It's in some books, definitely, because I recall what you're
Reka
saying.
book. In Reka 500, new book.
Is finer spirit. I think was it in the Bible? I can't remember.
I want to ask you something else. If you find sperms in urine, because this is the thing that the sperms are going to work in the urine, right? So what they are doing with these sperms? Are they washing it, or how they use it for ICSI?
After washing, I think.
Or centrifuging?
They alkalinize the urine and then collect the sperm.
There is a procedure of doing it for sure. So there is a medical treatment and there is a way that you can do ICSI with it. So there are two ways of, using these sperms. Are these sperms are mostly alive or they are dead?
No, they are not alive mostly.
Mostly are not alive. This is the problem. That's why you said they need ICSI, right? Now, what is the criteria of doing ICSI?
Severe oligospermia and obstructive and non-obstructive azoospermia.
Yeah.
And motility defect.
Or
Compound
where
less
there
than
is
1
failure
million.
of failure of previous IVF.
Yes. Failure of previous IVF. Yes, that's true. And what else?
Genetic diseases.
Yes. Okay. Because I want to finish, because it is written male factor infertility. So they talk about male factor. Let us finish male factor. Because in the guideline, they are writing everything here and there. Okay. Oh, where is for male factor? I want to finish. There's a talk article about male factor. I want to show you this. No. Yeah, there is a whole talk article about thyroid dysfunction and reproductive health. And there's a very nice thing. You know what you have to do if your TSH, you can take, this is from the talk article. And you can treat your patient according to this table. Very, very nice table. If so you have to keep your TSH 2.5, right? Milli international unit per ml. If it is 2.5 to 4.5, you just repeat TSH and you do thyroid autoantibodies. If the TSH in repeated one comes 2.5 or less, you don't have to do anything, and the positive antibodies, you just monitor thyroid function test and the fetal growth and inform the neonatologist. If the TSH is more than 4.5, you have to do T3, T4, thyroid autoantibodies. And if the TSH, and start treatment. And if the TSH is still this one, yeah, that's it. So you have to do T3, T4 level, check thyroid autoantibodies and start the treatment. But you inform neonatologist and check the fetal growth if the thyroid antibodies are positive. And here also, what you can do, if it is between 2.6 to 4.5, just start low dose thyroxine and repeat TSH after 6 weeks. Always TSH is repeated after 6 weeks. And your aim of TSH should be 2.5 or less. If antibodies are positive, always you have to monitor thyroid function test, because even if they are not abnormal, they can become abnormal, and fetal growth, and inform neonatologist. It's a very nice table. Anyway, this is yeah, assessment of infertile male. 2013. I have, I think, 3 slides from it. No, 4. No, it is more actually. Well, let's find out the causes. As you said, Kalman. So hypothalamic pituitary, hyperprolactinemia, also anabolic steroids if he's using hyper or hypothyroidism. Glucocorticoid excess, congenital, which is Klinefelter, Y chromosome microdeletion. Oh, okay. You see, Noonan, male Turner. Okay. Or cryptorchidism. Acquired can be injury, orchitis, trauma, varicocele, renal failure, liver failure, chemotherapy, radiotherapy, testicular tumors, and idiopathic. Post-testicular due to obstruction, cystic fibrosis, as you said. Now, this is Young syndrome, which is a post-testicular cause which causes obstructive azoospermia, or you can say, and congenital absence of vas deferens, which happens in cystic fibrosis. In acquired causes can be vasectomy, infection, chlamydia, gonorrhea. It causes obstruction, right? Or vasal injury. Disorders of sperm function or motility, immotile cilia syndrome, maturation defects, immunological infertility, globozoospermia. You know what is globozoospermia?
No, ma'am.
I think this is the
That is
defect.
when the morphology is zero. Zero
The head.
morphology.
Yes, it is something in the morphology. What is there in the morphology? What abnormalities?
The total morphology is zero with abnormal heads, appearing heads.
Yes, the head of the sperms are rounded. And what is the problem? Most of them are not alive. They're not functional. And
Can't penetrate.
yeah?
Can't penetrate eggs.
Yes, that is true. Sperm function problem, motility problem, and they are usually useless. Sexual dysfunction can be anything, erectile ejaculatory dysfunction. Now the diseases, diabetes mellitus, multiple sclerosis, spinal cord injury, pelvic injuries, they can also cause post-testicular semen analysis abnormalities. History, what you have.
Sorry to cut you short in the middle, madam. We wanted to know that the session is supposed to end in about 4 hours. Will we be able to cover it up in the remaining time?
Yes, because I'm finishing the guideline. And while I'm reading the guideline, whatever the things are coming, we are referring to the TOG article. This is the shortest way of, because I cannot go one by one TOG, although I have summary of all TOG articles, but I cannot deliver in 4 hours. That's why whatever topic in guideline, we try to touch this from the TOG article also. So surgical history, fertility history, you have to take all the history from the male, right? Like her previous pregnancies, duration of infertility, previous treatment, sexual history, medication. You see, you need to remember these medications. Can you remember these medications? What is affecting the semen analysis?
Yes, we can remember the few. Actually, there are a few questions that came related to the medication, specifically cimetidine. So yes, you're right, they're important.
You to remember the medications because they're asking. I noticed in recalls. So please, nitrofurantoin, cimetidine, sulfasalazine, spironolactone, alpha blockers, methotrexate, colchicine, amiodarone, antidepressants, phenothiazine, and chemotherapy. And anabolic steroids, smoking, alcohol, all is affecting semen analysis quality, recreational drugs, exposure to ionizing radiation, chronic heat, aniline dye, pesticide, lead exposure. You need to remember all this. And this is the new, we already read from the what you call it, parameters from the guideline. You see, this is from I'm thinking from where I saw this 3%. Just look at it. Yes, this is the reference limit or the average, but there is a range, 3 to 4. It is coming in the 95% confidence interval, so it is in the range. So whenever you ask for the semen analysis, you look down in the laboratory criteria, they will write it. In my reports, it is written 3 to 4%, the range.
Then 3% is considered as a normal then.
Yes, it is in the 95% confidence interval.
So we have to look for the reference ranges, whatever they mention in the reports.
Yeah, because I was thinking from where I saw this. So it is here in the TOG article.
Okay.
Yes, that's true. Even you can see even 1.4 is in the 95% confidence interval, right?
Yes, ma'am.
So we need to dig more in anything, even if you know if you remember the reference limit, you still have to see the 95% confidence interval because it is given in the TOG article. Okay, so for how long the man has to do abstinence?
For 3 days.
And what's the upper limit?
Just 2 to 5 days.
Okay.
Because prolonged abstinence will causes the decrease in the motility or
Yes, sperm motility will be decreased and they will start to die also. So not more than 5 days, and it is collected after 72 hours is 3 days, right?
right, ma'am.
Yeah. So 3 to 5 days. Okay, and then freeze the fresh semen is coagulated and liquefies 15 to 30 minutes after ejaculation. So that is why it should be brought to the sample should be brought. Sample should be kept at body temperature during transport, and sample should be analyzed within an hour of collection. This is another. If the man is doing it at home, if he's collecting at home, you have to tell him that you should bring the sample within 1 hour, keep it near to the body temperature. So low ejaculate less than 1.5 ml. It might be due to retrograde ejaculation. It might be due to obstruction, due to androgen deficiency or incomplete collection. There are 4 possibilities. And sometimes if the sperm count is less than 5 million, you have to check FSH, LH, testosterone and prolactin. If the count is less than 5 million means severe abnormality, right?
Yes.
Okay. And karyotyping is indicated in severe oligo and azoospermia, like Klinefelter and Y chromosome, long arm of Y chromosome, microdeletion.
Microdeletion of Y.
Yeah. So if there is,
ma'am, this azoospermia region A, B, C, is it important to remember?
For me, I did not. For me, this is not. I never consider it, but it is written here. The
Because
azoospermic
they say
factor
C
locus.
has a good prognosis, A and B has a bad
That
prognosis.
is
So in
true.
that
That is true.
context.
If you dig deep, you can, if you want, you can remember because it is there. It is written in the TOG article. But I have never seen asking in recalls very deep like this. But anyway, if you want to remember it.
Yes, there are no questions related.
Yeah, I have never.
There was a question asking about the genes that is responsible for certain diseases. I saw it, like in cystic fibrosis. What is the
TTFMR gene.
or
These are
like
really important and recurrent diseases, but this is not the one.
Okay, thank you,
Yes,
guys.
in recurrent miscarriage, these might be important. And sometimes things are important, like in trisomy 21, there is a gene responsible for recurrent miscarriage. If there is a trisomy, I think 21 to 21, whenever patient becomes pregnant, she will miscarry. So it is written in the recurrent miscarriage guidelines. There are some things that are important and that needs to be remembered, but the clinical significance of this is not very clear. So, and I never saw it in recalls also. So are you going to image, are you going to do a scrotal ultrasound? On physical examination, if you detect a testicular tumor or varicocele, that, but the problem is, the recommendation is, even if you find a varicocele and you correct surgically, it's not going to correct the semen abnormality. So it's not actually recommended, but you still, a man can do it because he might be symptomatic because of this varicocele, but it's not going to affect the semen parameter a lot. It's not going to improve. Testicular biopsy, you can do it if there is severe oligo and azoospermia. It can also facilitate. Actually, this is what we are doing. We are referring to the urologist, and they, after investigating, they will just go and do the testicular biopsy for ICSI. Now there are different approaches: open or percutaneous needle, and you can send it for the histopathology also. So if it is normal, means appropriate number of cells with complete spermatogenesis. Hypo means all cell types present but less number. Maturation arrest means failure of spermatogenesis beyond a certain stage, or Sertoli cell only syndrome means no germ cells. It can be anything. So in this case, you can tell him that, okay, we cannot help you. Del Castillo syndrome, Sertoli cell only syndrome, no germ cells. What you will do in this case? Sperm donation only,
Donor sperm.
or adoption.
Sperm
Okay.
donor.
Yes, and sometimes there is combination of things.
Excuse me, ma'am. There was a question that I was talking about. Genetic syndrome are associated with different gene mutation. The following are correctly matched except one. So the choices are hereditary breast and ovarian cancer, BRCA1-2, Lynch syndrome, MSH6, Lefraumeni, germline, TP53 mutation, Pitt-Jaeger, PMS2. So do we have to memorize all these? That was a question. I can't remember from where, but it was a shocking one.
For me, what I am doing, I never take care of these questions, and I leave it on my luck, and I will do a calculated guess for questions like this, because you cannot remember all these things. There's a lot.
No, of course.
Yeah, so you can do your guess sometimes, calculated guess. Luck.
Ma'am, one article on male infertility, the TOG article, they have mentioned one recent evidence that varicectomy in infertile men with impaired semen quality and palpable varicocele. So if we operate, then significantly improved semen characteristic and the chance of pregnancy followed by 1 year would be, it is mentioned over there. So do we
Which
have to, ma'am, there's one dog article, actually I have written it in my notes only, so I don't know.
Yeah, is it written?
Yeah, ma'am, it is written under recent evidences.
You see, this is what happened. Sometimes the recent TOG articles are showing us something recent, and the guidelines are not showing it because it is based on the. But then what you have to follow if the question comes, the guideline or the TOG article?
Guideline, obviously, ma'am.
Yes, just follow the guideline. Yes, if there is a contradiction, then you have to follow the guideline. Usually they don't give you question on if there is a conflict, or usually they don't give the questions like this, usually. But if there is, you follow your guideline. But in the guideline, it is written that doing varicocele surgery is not going to improve the, so we will We will just follow this one. There can be primary testicular failure. Maybe if he went through chemotherapy or something. Reversal of vasectomy. Success rate depends on the skill. Patency rates seem to decline with increasing time. And then what at the end, what TISA, TC, microsurgical, micro TC, PESA, MESA, all these are the names. These are the urologists, they're using these names for, you know, this is testicular sperm extraction. Okay. So if the man has obstructive azoospermia, of course, the success rate will be high, clinical pregnancy rate, because it's just the matter, like in the tubal obstruction, the success rate is high because our eggs are quality and quantity is good. The same way, the sperms are good, but there is obstruction. That's why mechanical obstruction. So if there is a mechanical obstruction anywhere, but there is no problem in the quality and quantity, the result is always good. It is written in this NICE recommends men
Ma'am,
should.
here it is written recent evidence from the randomized control trial. Wala. This thing I was talking.
It is written over here.
Yeah, ma'am, here. However, the recent evidence from the randomized control trial indicates that the varicectomy in an infertile man with impaired semen qualities and the palpable varicocele. This one I was talking, ma'am.
Oh, so it is written in this same article. Okay. NICE recommends men should not be offered surgery for varicocele as a form of fertility treatment, but it does because it does not improve pregnancy. This is what I was talking about. Now you are referring to
Yes,
this. However, recent evidence from a RCT indicates that varicocelectomy in infertile men with impaired semen quality and palpable varicoceles significantly improves semen characteristics and the chances of pregnancy within 1 year. Overall, the evidence is stronger with regard to an improvement in sperm parameters with less convincing evidence for this translating into the higher. That's why NICE do not recommend it. You know why? Because serum parameters might improve, but the spontaneous pregnancy rate will not improve a lot. So varicocelectomy may also correct the testosterone defect. So they will do it because they will
Yes,
still
ma'am.
do
This
it.
is also written in strategy exactly like the way that you said that NICE does not recommend this, that although it is a new RCT, but NICE doesn't recommend it, and we have to follow NICE. So you are right about this. It's in
Yeah.
strategy also.
Yeah, I don't know. I didn't read from the strategy, but this is what I'm thinking, that there is some reason why NICE do not recommend it, because it's not going to improve the spontaneous pregnancy rate. But the thing is, the men will go for it because it's going to correct the serum testosterone defect and low testosterone level, and there is the men are symptomatic if it is palpable varicocele. There are symptoms associated with it, so they can go it for some other reason, but it's not going to improve the spontaneous pregnancy rate.
Okay, so then for exam point of view, that it is not like recommended to operate the varicocele then.
For pregnancy, but
For pregnancy.
for other symptoms you can
Okay.
I mean you can recommend, because the man will be symptomatic because of this, and he will have low testosterone level. It can affect his sexual function. So yes, he can go for it, but it's not going to improve the pregnancy rate. It might even improve sperm parameters. That is the reason we have to understand why NICE do not recommend it for, because it's not going to improve the spontaneous pregnancy rate if you are doing it for this reason only. But for other reasons, they can do it. And of course, they can go for IUI, IVF, ICSI. Okay. This is what I wanted to say about male factor infertility. There is a very nice table in this talk article I want to show you. This is the article. Current issues in ovulation induction. Let's see this article, this table. You know that there are 3 groups. In the guideline, we will see now, because I was at the slide when the male infertility struck like lightning and we start talking about it. So we were at the slide of 3 groups, WHO groups, group 1, group 2, group 3 of anevolutory disorders, right? Group 1 is hypogonadotrophic hypogonadism, low FSH, LH, low EC. Because of athletes, anorexia nervosa, whatever, irradiation, Sheehan syndrome, Kalman syndrome, idiopathic. So what is the treatment? Correction of weight. Reduction is to avoid the causes. So you have to treat the primary cause and lifestyle measures. Then the drug treatment is both FSH, LH, gonadotrophins, not only FSH, both FSH, LH. Or you can give pulsatile GnRH pump or gonadotrophins, but always gonadotrophins are FSH, LH. And the next step after giving FSH, LH, go for IVF. Now let's see.
Excuse me, ma'am. I'm sorry I'm interrupting. There's this question. If the question asks about this type 1 disorder and the answer is, both the answers are there, gonadotropins as well as pulsatile release of the GnRH, which would be the most appropriate answer?
What do you think? So if you, for example, if both are effective, if some question appears in which both are effective, how you choose between one of them? In your practice, what you will see next? Both medications, both modalities are acceptable. You will choose according to the side effect profile and according to the cost and according to the comfort of the patient, the invasiveness or the easiness of treatment. So what do you think is the most easy and less more cost effective, sorry?
The pulsatile one?
Gonadotrophins.
Gonadotropin giving will be more easier.
Easier, cheaper option.
And
Yeah, easy to give, easy to control. We are
it is
familiar.
easy to give. We know how much dose we are giving, how much dose is acting over there. But in pulsatile GnRH, again, it depends how much secretion will be there, LH and FSH. Then we have to monitor it.
Yeah, it's you can say it's more difficult. I don't know the whole thing because I never give any patient pulsatile GnRH, but I know that it sounds difficult to me. So if some question comes like this, then you have to see the other what you call it, broaden your view. This is like you're sitting in a clinic and you have to choose. This is what they want to see, right? That while you're sitting in a clinic and the patient is in front of you, how you're going to deal with her. If you know that both of the modalities, treatment modalities are acceptable, how you will choose. And there is one trick. In the TOG article or in the guideline, if you find gonadotrophins written first, and this is what I noticed. It's not written anywhere, it's not a rule of thumb. This is what I noticed, that whatever is written first is the first option in the exam, in the EMQ. So gonadotrophins is written first, it means it will. I want you to notice also in recalls, you notice this thing, that if they give options and both options are going, so whatever is written first is the first choice. They are writing according to their preference also. So hyperprolactinemia can cause the group 1 or hypogonadotrophic hypogonadism, secondary hypothalamic hypogonadism. So this is primary and this is secondary. It can be due to medication. These medications can cause hyperprolactinemia. You need to remember. Even it is written in the TOG article, so you need to remember. Phenothiazines, metoclopramide, pituitary microadenomas, stress, exercise, PCOS, all can cause hyperprolactinemia. So you correct it medically or surgically, and then you can give dopamine agonist, bromocriptine, for example. And in group 2 is PCO, which is normogonadotrophic. So FSH is, LH is a little bit high, FH is on normal. E2 can be normal or high, It can be idiopathic or PCOS in group 2. So what is the treatment? You have to correct the weight, lifestyle, give clomiphene, or nowadays they are talking about, there is a talk article about ovulation induction current, what do you call it? I will show you anyway. Current modalities of ovulation induction, something like, so they talk about letrozole also. So here they talk about clomiphene, 6 to 9 cycles. If she is ovulating, you can continue up to 9 cycles also. Or the next step is gonadotrophins, laparoscopic ovarian drilling. Last option is IVF. So you can see in PCO, what are the options? Is IUI is an option of for PCO? Is it a treatment option?
No.
No.
No,
It is
ma'am.
not. It's either ovulation and weight reduction, lifestyle. First, number 1. Second number, either clomiphene or letrozole, whatever. And then number 3, gonadotrophins or laparoscopic ovarian drilling, if indicated. That's it. Full stop. No IUI. Or at the end, IVF. Now I want to ask you about the indications of laparoscopic ovarian drilling.
When patient is resistant to
It is
gonadotropin
used
therapy
for the
also, then
resistant cases.
And
Is
in lean
normal body mass
PCOS,
index.
Yes.
lean PCOD patients also it is indicated
Yes.
as a first line after
That's
clomiphene.
So for
The
the
ones that do not respond to clomiphene or to the gonadotrophins, then we, for those resistant cases, we choose this option of ovarian drilling.
yes, that is true if they are resistant. But what about if the patient is, as doctor said, that you can even give it as a first option if she is a thin
It's in patient.
PO. Why?
Lean PCO.
Because
Violet.
what is the advantage of laparoscopic ovarian drilling on top of
it will
Prevents
decrease as
OHSS.
the ovarian stroma is getting.
No risk of multifollicular
It
death.
reduces the risk of ovarian hyperstimulation.
yes,
Decrease the stromal androgen.
yes, yes, and one more.
Multiple risk of multiple pregnancies.
Multiple pregnancies also it reduces.
Yeah. So because it is invasive,
It
that's why
normalizes the normal function of the ovaries, so we don't have to get worried about the assisted reproductive techniques problems in this. It just normalizes the ovarian function of the body.
yeah, but because it is invasive, that's why they do not put it as the they are putting it as the according to indication. And nowadays there is a problem with laparoscopic ovarian drilling. You know what is the problem? Now you told me the advantages. What is the
Ovarian tissue is destroyed.
Chance of premature
So there is
ovarian
no
failure,
yes,
like we are.
we don't like to do it, especially we don't like a general for me as IVF specialist, I don't want a general gynecologist to do. If I want to do it, I want to do it by myself, because you have to be very careful. So how careful, how you do the laparoscopic ovarian drilling?
We put the fluid in the POD so as to decrease the temperature, and there will be less adhesion will be formed.
Number
And
1,
we'll give the four. We'll be giving 4 puncture with a 40 watt for 4 seconds.
yes, there's a rule
At
of 444. This is what I remember.
Yeah, ma'am. Yeah, 4 for 4 seconds, 40 watt current.
Yeah, that's true. Not more than this. And you allow the ovary to cool down so that it will not touch the and will make the adhesion. It can cause thermal injury as well, because you want to avoid thermal injury and you want to avoid adhesions also. So you need to
And
cool.
ma'am, avoid the drilling at the ovarian hilus area because of.
Yes, that is true.
Ma'am, can you please brief us about this lean PCO?
Yeah, in lean PCO, what you can do, what's her option? For an obese, you can say that, okay, go and correct your weight, lifestyle factors. And even if you will give her like, yeah, you can give her clomiphene citrate. Why not? Yeah. But
so what should be the first line management for a lean PCO whose BMI is normal?
Clomiphene citrate or letrozole for sure. It's not, LOD is not the first line.
Ma'am, in recent history, they are saying like ovulation induction drug of choice in PCOS is letrozole. Can we go with that, or we should always go with the clomiphene, which we are using commonly now?
Okay. Now, what is written in the guideline?
Follow the guidelines.
Clomiphene is written in the guideline.
Results of Clomid in real life are also better as compared to letrozole so far that we have observed.
I don't know. I am IVF specialist and I am giving letrozole. Why? What is the advantage of it? Is written in the talk article, but what is the advantage of letrozole?
It causes monofollicular development. It prevents multiple follicular development.
Yes. And
prevents
maintain
OHSS, prevents multiple pregnancies.
It has negative effect on usually clomiphene citrate has negative effect on the endometrium and cervix.
Yeah.
That is not there in letrozole.
Yes, negative effect on cervical mucus and endometrium, which is not there in letrozole. And the success rate, I mean, we want high success rate. The success rate is higher while we give letrozole, and it is written in the talk article. The success rate with letrozole is higher than clomiphene citrate. So why we are not giving it? By the way, in US, if you go to the US guideline, American Medical Association in Obs and Gynae, they are talking about their letrozole is number 1. In WHO, letrozole is number 1. Only in the NICE guideline, they do not mention anything about letrozole. But usually in the EMQ, they don't ask controversial questions. But if you ask me, practically speaking, I will give letrozole.
Okay, ma'am. Thank you.
Ma'am, one more thing, like how many cycles of ovulation induction we can give? Because in NICE they say it's 6 cycles of we give, and in some TOG 6 to 9, as it recently we have seen 6 to 9 cycles. Somewhere it is mentioned 12. So how much exactly we can? Because if we go ahead with the guideline, it is 6 cycles.
Yes, NICE recommends 6. WHO recommend 12. So most of the obstetrician are between 6 and 9.
Okay.
That's why they are giving here 6 to 9. I give maximum 9. I don't reach 12 because the patients also don't want to reach 12 cycles.
Yeah, exactly, ma'am.
Yeah, patients will deny, but there you have both evidences. No one will sue you if you will give 12 because it is WHO guideline. You can give up to 12. In NICE, it is written 6. It's okay. So, but you have maximum. No one can sue you, what I mean. But usually what obstetricians are doing, gynecologists are doing, they are giving 6 to 9.
Okay, ma'am.
That's why it is
And
mentioned.
there is one more thing, as you said that LOD we can consider it as a first modality in some cases. But ma'am, in guidelines they mention that if we use LOD, the 54% chances of the additional patient which requires the ovulation induction along with LOD also. So still we do recommend we can opt LOD as a first choice in some group of patient.
Yeah, for me, I don't go it as a first choice.
Okay.
It is clomiphene citrate or letrozole, whatever you are giving. This is always the first choice. If she is obese, lifestyle. If she is not obese, ask her to maintain the weight and go for the clomiphene or what you call it. And even gonadotrophins. There are 3 options, by the way. It is even gonadotrophin and not gonadotrophins, sorry. The metformin, the
Clomiphene plus metformin and gonadotropin. Clomiphene plus metformin and gonadotropin. These 3 options.
Yeah, there are 3 options. That's true. Still, I will keep LOD as a last because it is invasive anyway.
And ma'am, using
Yes, ma'am,
metformin
proceed
decreases
further. Thank you.
No one will blame you if you will go after clomiphene, if you will go directly to the LOD instead of going to the gonadotrophins. No one will blame you. This is what I want to say.
Yeah, ma'am. Thank you, ma'am.
Yeah.
Ma'am,
So we already talk about premature ovarian failure and the
Hello.
yes.
Hello. Yeah, ma'am, I joined late. I just want to ask for hyperprolactinemia. First line is what? Bromocriptine or cabergoline for exam purpose?
For exam purpose, if they are giving two choices, bromocriptine or cabergoline, what you will choose? What you will choose is according to the two things: side effect profile, cost effectiveness, because both are effective. If anything, we were
Practically, we are
just
using cabergoline, but for exam purpose, what
for
we should
exam
choose?
purpose is bromocriptine. You know why? Because you joined late, we were just discussing that if same same efficacy is the same, how we choose. If the efficacy of two treatment modalities are same, how we choose? We
But
choose
ma'am, side effects are more with bromocriptine.
we choose according to the side effect and we choose according to the cost effectiveness. Now, if you have more side effects, but it is more cheap, then what you will do? You go according to the guideline. What is written in the guideline? Right?
Okay.
Bromocriptine
Okay.
in the guideline.
Ma'am,
As far as
guideline, they said that safety use in pregnancy.
yes, both are safe to use in pregnancy, but bromocriptine has more safety.
More consideration.
Yeah, longer what you call it, longer data for safety. But cabergoline is equally until now people are using it and it's safe. So both can be used, both are right, there is no right, there is no wrong, but it is written in the guideline bromocriptine because NHS is always thinking about cost effectiveness. But you have to inform the patient that this will be side effect. If she want to choose this, then she can then if she will not accept the side effects, then she can go for this one. But if you ask me about the first choice, we go according to what is written in the NICE guideline.
Okay. Okay, thank you.
Thank you very much. Let's complete our guideline because I finish almost most. There is one more thing because we are talking about PCO. Anyone tell me the definition of PCO?
Is Rotterdam's criteria.
Rotterdam criteria, ma'am.
Yes. So what is the Rotterdam criteria?
It includes the three things. One is the oligo or anovulation. The second is the insulin resistant. Third is there is a hyperandrogenism, which is characterized by hirsutism. So these
No.
three things.
No, the third one is
No. The third one is
PCOS on the
the
ultrasound.
ultrasound characteristics of
Sorry,
Yes.
sonographic
PCOS.
criteria. 12
Second one
follicles.
is
Yeah, let's go one by one. So either
yeah, ma'am.
two of the three things should be there in order to define or in order to
SPCOS.
what you could diagnose PCO. And it's a diagnosis of exclusion. So you have to do prolactin and TSH, and you have to find out maybe there's some other
Late
reason for
CH.
ovulation, right? Yes. So once you exclude everything else, then you check two things out of three. So one thing, let's come one by one. So menstrual disturbances or
Irregularity.
menstrual irregularity or infertility, right?
Anovulation.
Yeah, anovulation.
Let's see. This is exactly what is written in the guideline. Rotterdam criteria. Ovaries, it means ultrasound. And it is written 12 or more follicles or increase ovarian volume more than 10 cubic centimeter. So 12 or more follicles, and we will discuss about it.
Yeah, ma'am. In the actual recent X-ray, they have given 20 or more follicles, na ma'am.
In
X-ray guidelines, X-ray 2018 guidelines, they have given the number of follicles to be 20, na ma'am. Ovarian volume, they have given the same 10, ma'am, but number of follicles, they have increased to 20.
So what
I
you
don't
will
know which one to follow. Yeah, ma'am, I don't know.
But we have to follow the guideline here, not the ESHRE.
ESHRE usually they are not following. They follow the guideline. If at the RCOG site, if they give you a link of ESHRE, you follow that ESHRE.
Okay, ma'am.
But if they are not giving the link, sometimes you open the guideline and you have a link of ESHRE guideline, right? Like in, I think, endometriosis or something. Don't remember. But if they don't give a link, it means they don't want to consider. So this is how you decide whether to follow it or not. If in the RCOG site there is a link. So clinical or biochemical signs of, okay, oligo-ovulation or anovulation. This is how exactly what is written. So polycystic ovaries, what we know is there should be 12 or more follicles. Now this 12 or more follicles, which is defined in the TOG article, so is it written that it should be peripherally arranged, or it can be anywhere? Is it necessary to be peripherally arranged?
But previously it was said that
It's
the
not
pearl
written.
sign appearance is supposed to be necessary, but not anymore.
Not anymore. It's not necessary. This is what I want to realize. And the other thing is if you have 12 in one ovary or more than 12 and the other ovary has 6 or 7, you will still call it PCO, or it should be in both ovaries?
No, even one ovary.
No, ma'am, one
It-
ovary. It
Yes.
can be in one ovary as well.
Because it is not written that it should be bilateral, and in the TOG article I saw it written there, because there is a TOG article about PCO, I think 2 or 3 TOG articles. So it is written over there that it can be in one ovary also. Okay. And the other features. What are the other features? The stroma you will find the stroma a little bit thick, and the volume and the number of follicles. It can be either in one ovary or 2 ovaries, 12 or more than 12. What is the size?
2 to
2 to
9
9
mm.
mm.
9 mm.
This is what it is written in the TOG article, right? But it is not mentioned in the guideline because it's not, the description is not written how the follicles should be. Okay, but you will find it in the TOG article. Now, oligo-ovulation or anovulation. What does it mean? Is it the menstrual irregularity
Ovulation
or
means
it
no
is the
menses for
infertility?
6 months.
Yes, but
And oligo-ovulation means 4 cycles,
Mhm.
6 cycles per year.
Yes, this is the definition of oligo-ovulation. So anything less than 6 is, you will consider it. How you will judge the ovulation?
Serum progesterone.
First of all,
Regularity of the cycles.
if the irregular cycle, then you will check the by the way, day 21
On
serum progesterone is the baseline
day,
investigation.
25 day, and
Yes. So you will know from the day 21 serum progesterone, and it's a baseline investigation. Are you going to do it even in regular menstruation?
Yes.
Yes.
Yes, ma'am.
Yes, we have
To
to
confirm ovulation.
Yeah. So this is a baseline.
document.
It is baseline, and you will know from there, even if she's having regular menstruation, it is possible that she's not ovulating. Even if she has regular menstruation, there is a possibility. That's why it's a baseline test. So once you find by doing day 21 serum progesterone that she is having oligo-ovulation or anovulation, then you will go on and check the causes. Maybe TSH, maybe prolactin, FSH, LH. You will go
ma'am,
and
can you repeat the definition of oligovulation and ovulation, the differences?
where it is written, because I don't know where it is written. But actually, he's right.
Yes. Okay, now I know the oligopulation means yearly 4 times menstruating like this. But anovulation, what does this mean?
1
I'm
second.
not clear here.
Times or 4 times? Just check from the Google because I don't know where I left my cell phone. Just check in the Google what it is written over there.
Okay, ma'am. Yeah. Okay, no problem.
And then tell me, yeah? Because it might
Okay,
be
ma'am.
4 or 6. You are right.
Mhm.
I have to find out. Okay. So, or maybe, or you will know that maybe because she is infertility patient. So this is one of the things that you can say, okay, but you should have evidence of anevolution or oligoevolution, right? So clinical signs of what are the clinical signs?
Hirsutism. Hirsutism.
So if you find a patient with hirsutism, acne, male-like baldness, yeah, usually what we do,
Deepness of voice
yeah.
also.
yeah, clitoromegaly, deepness of voice, reduction of the
Yeah.
size of the breast. These are all signs of hyperandrogenism. But the question is, are you going to diagnose her after doing the testosterone level? The answer is no. You are diagnosing PCO on the basis of clinical or
Or
biochemical, isn't it?
yes, ma'am.
And or. So either it can be both or it can be one. So once you see any patient with hirsutism, he is not what you call it, she's not getting pregnant, she is having menstrual irregularity. Without looking at any investigation, you can say that this is PCO patient, even without doing ultrasound. So it should be noted that the diagnosis of PCO can only be made when other etiologies for irregular cycles, like as I told you, it's a diagnosis of exclusion. You have to rule out thyroid dysfunction, hyperprolactinemia, and acromegaly.
And ma'am, for biochemical signs of hyperandrogenism, the test we do normally is a free testosterone level or free androgen index, na ma'am?
You know,
No, the free androgen index, I think.
The androgen index is more considered.
Yeah, free, and what they recommend in the guideline is free androgen index.
Androgen index.
Which is not free testosterone, which is total testosterone divided by sex hormone binding globulin. And you know, if you ask any endocrinologist, he will ask you to do total testosterone level, not free testosterone, and divided by sex. So what is, we go according to the guideline. Free androgen index, which
Free
includes
androgen index.
not free testosterone, it includes total testosterone level.
Okay,
Ma'am, I have a question. Previously, we used to discuss that in PCOS, LH and FSH ratio is reversed. LH is more as compared to FSH. Now we do not do that anymore.
There is no need to do it because it's a waste of money. Even if her LH is high, you are not going to diagnose her on this basis. But if the patient is going for IVF, I might do it because LH is, to check LH maybe is important in this case, because in the guideline it
And
is
if
written
ma'am,
FSH and LH.
we have to choose between LH FSH ratio and total testosterone level. So if we have to choose one test, biochemical test from these two for PCOS, which are we going to choose? Which is superior?
In order to diagnose PCO, you don't need to do any of these tests. You can diagnose it. Now, if you want to choose, if there is hyperandrogenism and you want to check the biochemical diagnosis, then what you are doing is the free androgen index. But
Okay, ma'am, thank you.
LH is not part of the diagnosis. But if the patient is going for IVF and she has an evolution or irregular cycle, then it is recommended to do FSH-LH as a baseline investigation. Because she has irregular menstruation, as it is written in the NICE guideline, that if a patient has irregular menstruation, FSH-LH is recommended as a baseline. This is the time that you will do it. Otherwise, you don't do it. For me, for example, in PCO patients, in order to diagnose PCO patients, I don't even need to do FSH and LH. Yeah, I will do it if she has irregular menstruation and she is a case of infertility, then I will do. There should be an indication to do FSH LH. PCO patient might come to you because she has irregular menstruation. Maybe infertility is not her problem. So why you should do FSH LH if she has irregular menstruation? And she has hirsutism and you predict that she's maybe PCO, why should I do it? No, if she is infertile, I will do it. And if she has irregular menstruation, she looks like PCO, or she has ultrasound which shows PCO, and she want to be treated for infertility, then I will do it, FSH LH. So everything is according to the scenario, you know. Anyway, let's come back to our guideline because we were talking. Yeah, this one very interesting. Let me show you something. Where we were. So we have like 30 minutes only, and in 30 minutes I want to show you this one. We already talk about most of the things, so I'll go. Let's talk about, we already talk about in intrauterine insemination. Let's talk about for people with, and we already talk about what is the indication of IVF? Unexplained infertility, more than 2 years of infertility, she can go for IVF. But there are 3 indications in which she can go for IUI before IVF. Relative indication for IUI. Remember, we talked about relative indication of IUI, not absolute indication. So
yeah, mild factors and yeah.
Yeah, it is written over there. This is from where we, but actually if unexplained and if any of these problem and it is more than 2 years infertility, the first line is IVF. But for cultural, social or religious objection to IVF, she can go for IUI. So it's a relative indication, you can say. So how you judge that this IVF will be successful? It depends upon the age, right? It depends upon the number of previous treatment cycles. If she become pregnant before, even if she has miscarriage, but she was pregnant, high chances of live birth. Previous pregnancy history, unsuccessful cycle. So if she has more unsuccessful cycles, treatment cycles, IVF cycles, it means chances become less. So what is the cutoff? After how many cycles you can say, after this, her chances become less? It's not that you will deny, you will not do IVF for her, no. But her chances will become less. After how many cycles?
3.
After 3. So up to 3 cycles, she has more or less the same success rate. As the number of cycles increasing, after 3, then the chances is becoming less and less. And previous pregnancy, BMI, as we discussed, 19 to 30. Lifestyle, alcohol, smoking. Now, you see, I want to show you, people should be informed. Maternal caffeine consumption has adverse effect on the success rate of ART, including IVF. Even if she go for IUI, you have to tell her stop drinking caffeine. It's not only for IVF, it's for IUI also.
Ma'am, one more question here that previous pregnancy, we said if there is a history of previous pregnancy, she has more chances of success with IVF. Is this pregnancy IVF pregnancy or it is a natural spontaneous pregnancy?
Any pregnancy, spontaneous or IVF. Even if she
Because
becomes
there
pregnant
was a question on this also, that
yes.
Whether it is more with natural pregnancy or more with IVF, if previous history of any
so
IVF
you have
pregnancy.
to choose, right?
Yeah, but I don't know. I haven't seen anywhere written as IVF pregnancy. Everywhere it is written as previous pregnancy. Nothing is mentioned whether it is natural or it looks like natural only, but nothing is in particular written as IVF
I have never
pregnancy.
seen written anywhere. But if I will assume as a natural pregnancy is a better predictor. But I'm only assuming. I never saw it written anywhere.
Yes, it is not written anywhere, yes, ma'am.
So for the things that you are assuming, just assume and pray. Maybe it's just by chance, by luck. It's a calculated risk. Sometimes you have to take in EMQs, right? Not everything is black and white. So lifestyle, we already talked about it. And now this is the thing which I want to show you. Full cycle. What is the meaning of full cycle of IVF? In which one episode of ovarian stimulation and transfer of fresh and frozen embryos. This is the full cycle. Now there is a criteria: less than 40 years of age. She has not conceived after 2 years of regular unprotected intercourse. So what is the definition? After 1 year, you diagnose her that she has subfertility. When you will go for IVF? After 2 years, right? Or she has gone through 12 cycles of artificial insemination, where 6 should be intrauterine. The rest can be intracervical, no problem. So you can offer 3 full cycles. So NHS is offering 3 full cycles. It doesn't mean that she has to get only 3 cycles. You can go to the private and get the other cycles. But NHS is offering 3 full cycles. If the woman reaches the age of 40, do not offer the further full cycles. Okay, between 40 to 42 years, who have not conceived after 2 years or 12 artificial insemination, offer one. So for more than 40, it's until 42 is one full cycle. Provided the following 3 criteria are fulfilled. They never receive IVF before, no evidence of low ovarian reserve, as we discussed before, and there is a discussion. So if a woman is more than 40, you have to discuss the implication of IVF and pregnancy at this stage. Okay. Management and where IVF is the okay. In women under 40 years with previous full IVF cycle, self or NH, so it will be, even if she did it private, she will still be counted in the 3. Okay. So what is the cancelled? What is the definition of cancelled cycle? So where you have not when the egg collection process is not done or ovum pickup is not done, it is considered cancelled cycle. Okay. Pre-treatment. Some IVF specialists are giving OCPs or progesterone before starting any protocol, but they are saying that it's not going to it's not going to increase the chances. Consider pre-treatment in order to schedule the IVF treatment. If you want to say that, okay, I will do it after 2 months, or there is a lockdown or a pandemic for 3 months, so, and you want to end this month exactly, or my partner is coming, he is overseas and he's coming on this date, then you can schedule your IVF treatment and give her OCPs because of this. But you cannot give it if you are giving it down regulation protocol. Only antagonist protocol you can give OCPs, for example. And consider down regulation protocol to avoid the premature LH surges. If you go and give antagonist protocol, there is a higher risk of premature LH surges. That's why you need to check the LH levels also. And when the LH level is increasing, you know what is the meaning of protocols? What are the kinds of protocols? There is
ultra long and long and
Long acting, short acting, ultra short
and
acting
short.
protocols.
Yeah. In long
Agonist and
protocol, in
antagonist.
down regulation protocol, what you give, how you do it? You
We
are doing
start
down regulation.
We are starting the previous
gonadal
cycle.
at day 21
Yeah, day
after
21.
previous
Okay.
cycle.
And what you give?
And then gonadotropins from day 2.
No, not gonadotrophins. You need to down regulate.
Gonadotrophin releasing hormone.
Yeah. Kinara,
Egg oil.
That we give from day 21.
You give
GnRH
leuprolide.
Either GnRH agonist or antagonist, both of them.
Yes, GnRH, usually we are giving GnRH agonist to suppress for almost 2 weeks. And after this, you will find the ovaries are completely suppressed, endometrium is very thin, and then you start giving her gonadotrophins.
Yeah, from day 2.
FSH, LH. And usually we are giving the combination. So once you are monitoring by ultrasound, you are doing folliculometry, you are checking your E2 and LH levels also. Right? In different centers, they are some people are checking every 2 days, some people are checking 2 times in a week, 3 times in a whatever. So you are checking your LH level, and once you're and you are doing folliculometry, right? So you should suppress your LH is suppressed. It is usually less than 2. It is suppressed, and on day 4 or day 5, by ultrasound, you will see one follicle becomes the size of the follicles. It says, what is the cutoff? Is there a cutoff? It can be 14 millimeter, 15 millimeter, or 13 millimeter, no problem. But on the average, around 14 millimeter size. And LH is still suppressed. Then you will add, this is the, no, I'm telling you about the agonist protocol. Sorry. So you continue on giving gonadotrophins, and you will continue on checking LH and E2 and folliculometry, the follicle size. So what is the best follicle size to trigger? And how many follicles should be there once you say that she is ready and we will trigger?
18 to 20 is the good
18,
size.
18 to 22 or something.
Yeah, anything more than 17 millimeter is fine, then you can trigger. Once you trigger it. If you are worried about hyperstimulation, you trigger it, but you cannot trigger if you are giving gonadotrophins or agonist protocol. You cannot trigger with agonist.
Agonist.
Oh.
You can only trigger if
Yes,
you
it
are
should be
giving
HCG.
antagonist protocol.
Or HCG.
You have to use SCG in a agonist protocol, because you can only trigger with agonist in an antagonist protocol. And you will find all this information in the TOG articles, And okay, more than 17 millimeter, 3 follicles, or more than 3 follicles of 17 millimeter or more in size, you will trigger with SCG. And then you will go after 32 hours, you will go and do the egg collection, right? Under conscious sedation. NICE recommends under conscious sedation. After you will do the egg collection, you will give it to the embryologist. They will do all the procedure, IVF or ICSI, whatever is the indication, because you know the indication of ICSI also. So they will do it. And then what is the most preferred day for embryo transfer? Day 5 or day 5?
Day 5.
Day 3. Day 5.
Day 5 stage.
It is blastocyst stage, but why? What is the advantage?
Because if the embryo is a good quality, is not good quality, then it will not grow by that time.
Yes, many of the embryos which are not of good quality, they stop growing. They arrest before day 5. So the chances of pregnancy rate is higher with blastocyst stage, and the chances of miscarriages are low. So we prefer day 5 blastocyst stage. And what is the protocol of antagonist? Antagonist, you start from day 2. You don't give GnRH agonist, nothing. Ask the patient to come on day 2. You will do the ultrasound, you will check her LH and E2 level, and then what you will give her? Gonadotrophins. This I was telling you, and I was mixing before. Then you are checking the follicle size. Once one follicle reach 13, 14 or 15 millimeter, one follicle only, you will add antagonist, which is usually cetrotide. Once you add
Sorry, Dr. Samira.
Yeah.
Sorry.
Sorry, just please, can you repeat again this main difference between agonist and antagonist?
In agonist, you are down regulating. You give GnRH agonist for 2 weeks and you down regulate the ovaries and endometrium. Then after 2 weeks, when everything is suppressed, you start gonadotrophins, FSH, LH. And you continue checking by ultrasound. And you are checking your E2 level, right? And once the follicle, 3 follicles or more than 3 follicles are 17 millimeter or more in size, you give her HCG for trigger. And after 32 hours, you do egg collection. And after 5 days in blastocyst stage, you do embryo transfer. That's it. This is agonist protocol.
And this this one
Antagonist.
ovarian hyperstimulation is high.
Yeah. For patients who have high risk for hyperstimulation, you don't do agonist protocol. You do antagonist protocol. And what is antagonist protocol? On day 2, you will start gonadotrophins. You are checking the follicle size. You will add your antagonist on day 4 or day 5 whenever the size of the follicle is 13, 14 or 15 millimeter. One follicle only you need that size. And your LH should be suppressed. If your LH is becoming more higher, it means that patient will overload, will have LH surge, and you don't want to have LH surge. That's why you will add GnRH antagonist on once the LH is suppressed less than 2 and one follicle is 13, 14 or 15 millimeter in size. It usually happens in day 5, sometimes in day 6. Okay, you add antagonist and then again you are checking the follicular size. The same criteria, 3 or more follicles more than 17 millimeter, you trigger. Now, if you are afraid of hyperstimulation, you trigger it with agonist. In antagonist protocol, you can trigger with agonist. And the same procedure after 32 hours, you do egg collection, and after 5 days, you do embryo transfer. Now, what about luteal support? How you do the luteal support?
With the progesterone.
What is
With
recommended in the guidelines?
Progesterone.
micronized progesterone.
Yes.
There is too much background noise.
Let me see. Okay, Dr. Ramya, she already closed her mic. Okay, so yes, progesterone is recommended and micronized progesterone is recommended. Now, if someone is familiar with the ASHRAE guideline and with the new modality, they are talking about dufestone, which is dydrogestrone. They are saying that there is a growing evidence that this has same effect like micronized progesterone, and it is more cheaper and less and more easier to use and more cheaper. But it is not standard of care yet. Standard of care is still micronized progesterone. But anyway, what they are writing in the NICE guideline, they do not mention. Let me see what they are writing about the luteal support.
Ma'am, in ART talk article, they mentioned that there is no difference with the route of progesterone, but internationally we identified the vaginal preparation are the preferred one.
You see, they are writing progesterone. That's it. They don't go into the detail of micronized or oral or anything. But in ASHRAE, it is written micronized first, and there is growing evidence that dydrogestrone or oral is as equal or even more effective than micronized. It is in the ASHRAE. So what you are saying, what is it in the new talk?
In the ART talk, it is mentioned there is no difference with the route of progesterone in terms of effect, and international survey identified that vaginal preparations are more preferred in ART talk.
Yeah. So the RCOG is still recommending in the vaginal micronized progesterone. But as I said, in ASHRAE, there is a growing evidence of oral also, but it is not yet the standard of care.
So for exam purpose, micronized progesterone only.
Yes, of course. So what is the indication of ICSI? We already talked about it. Okay, there is a genetic issue like testing for Y chromosome microdeletion should not be regarded as a routine investigation before ICSI. Okay. Either you go for now in some centers, they don't do IVF. Like where I was working before in Middle East, they were doing ICSI for all patients. What do you think? Why?
Fertilization rates will improve
Because
with
they have
ICSI, but
perception.
pregnancy rates are same.
Yeah, they have perception that it improves the success rate. But actually, if you dig down, it will improve fertilization rate. So if someone, that is why the indication of ICSI, if someone has fertilization problem, you see, what is the indication here? In addition, treatment by ICSI should be considered for couples in whom a previous IVF treatment cycle has resulted in failed or very poor fertilization, because it is effective for fertilization. So overall, it is increasing the success rate because it improves fertilization. But if once fertilization is achieved, then it's the same. So overall, ICSI is more expensive. It requires more sophisticated technique, more expertise, more time, more expense. So
Ma'am, is there any association? Is there any association of ICSI with the genetic abnormality
yeah,
in
they
the
are saying
offspring?
that yes, they are saying that because you are doing ICSI for severe defect of semen quality, right? So there is a higher chance that the child that will be born might have like Y microsome microdeletion or something, or karyotypic. If you are not testing men karyotype, then it might happen because you are doing ICSI for severe defects of semen quality, and the reason can be chromosomal or genetic, right? And you are not testing for Y chromosome microdeletion. No one is testing for it. It's not a routine investigation before ICSI, but it can cause significant promotion of male infertility results from abnormalities on gene, and couples should be informed of this.
So, ma'am, which one has the good pregnancy rate? Means like with ICSI or IVF? Because in NICE fertility guideline, they mention fertilization rate is better with ICSI, but pregnancy rate is no better than IVF.
You know, I want you to understand this, that overall success rate with ICSI is higher overall. But if you divide it up to the fertilization and after fertilization, then how the success rate is higher? Because it improves fertilization rate. So if someone has fertilization problem, so we will not give as a routine. NHS will never do anything which is more expensive, and it requires more expertise and more time. Time is money for them, right?
Right,
So
ma'am.
if someone has fertilization problem and you recognize it in the IVF, then you can go for ICSI, because overall it's going to improve. In Middle East, where I was working, money was not a problem. They just want to improve their success rate, right? But we are going for UK exam. That's why we always need to consider about the cost effectiveness.
And ma'am, ICSI success rate is 33%, no?
Generally speaking, it's between 30 to 40%, somewhere between 30 to 40. This is generally all IVF and ICSI. And you can say, okay, ICSI is a little bit higher. How much higher? I don't think it's more than 40, but it's never written in anywhere it's more than 40%. The range is between 30 to 40%.
Okay, ma'am. Thank you, ma'am.
Donor insemination, you know the indication: obstetric azoospermia, non-obstetric severe defect, who do not want to go for ICSI, they can have donor. And if there is a high risk of having genetic disorder, transmitting infection, severe rhesus, isoimmunity, all these indications are written over there. So intracervical insemination can be done at home also, as I said. And if they are using donor sperm, then they should not go for intracervical insemination. They should go for IUI because they are using donor sperms. It is better to use IUI instead of intracervical. Unstimulated, if the woman is ovulating regularly, they can go for 6 cycles of donor insemination without ovarian stimulation. So there is an option that they can do, like if they are using, I mean, they can do 6 cycles of donor insemination without ovarian stimulation to reduce the risk of multiple pregnancy. Anyway, so they can use 3 cycles and then you can check HSG. Before IUI, you should always check the baseline. Baseline is hysterosalpingogram. You have to see if the tubes are patent or not. But in intracervical insemination, 3 cycles she can take without looking at the tubal assessment. What is the
Excuse me,
indication?
ma'am, I have a question.
Yeah.
I don't know if it has a relation to this topic or not, but I was reading about the donor sperm and this stuff and the surrogate mother, okay?
Yeah.
And there was issue about who is, the legal father and all these things. Are these related to here or this?
Yeah, it's a surrogacy. Surrogacy
Yeah.
is a related topic. And there is a very nice talk article about surrogacy. All the rules of surrogacy are over there. I think they are dividing it into 2 categories.
Yes.
Yeah. One is
Yeah.
hmm.
But there is something I didn't understand. They said that the surrogate mother with a donor sperm, if she has a partner, he will be the legal father to the baby. If she doesn't have a partner, so the like the one of the couple will be the father. So I didn't understand
I
this
think they
about
are
the
talking
partner.
about the people who are in a what you call a lawful relationship, like they are married.
Yeah.
Yeah, they are talking
Yeah,
about.
if she didn't, if she refused to give them the baby or decided to like this, yeah.
Now, who has the legal power of refusing that I don't want to give the baby?
Is the mother that is carrying the
Mother
baby.
only.
That the mother who
The
is
surrogate mother.
yeah. Yes, the mother who is carrying the baby. That's true. She is having the legal authority. And then within how many weeks you need to, or within how many months you need to take the
6
consent?
months.
6 months.
6 months.
6 weeks to 6 months. Yes.
Hmm.
You should finish all your paperwork in order to become the legal parent.
Yeah.
And there are 2 kinds of surrogacy. It's all in the surrogacy,
The full one and the partial one.
the full and the partial. Yeah. In which there is a genetic child, and for the other one they use donor, so it's not genetically related to both the parents.
Yeah.
So I want,
Hello,
yes,
thank you, ma'am. Dr. Samira,
yes.
I want to ask what is the difference between intracervical insemination and IUI in relation to the investigations that done before? I mean, when there is a couple, infertile couple, I make the baseline investigation like progesterone level and hysterosalpingogram or laparoscope and dye to assess the tubal patency. Here you mentioned that when we make intracervical insemination, we don't make tubal patency.
That is true. It is written in the NICE guideline that there is indication to do artificial insemination, and it is given in the guideline what are the indications. For example, same-sex couple. For example, I'm just giving you an example. So if a woman want to do intracervical insemination at home from her partner, okay, which is a legal partner, she is doing it at home, there is a special syringe that they can fill this syringe with the semen and then push it near the cervix. She can do it even at home.
Okay, without any baseline investigation, يعني without any investigation like in IUI?
Yeah, there can be investigation, but not necessarily HSG or tubal assessment. So there are other investigations, but not HSG. It's not necessary. HSD can be done. It's not that it should not be done. It can be done, but not necessary. She can have 3 cycles of intracervical insemination at home.
Oh,
Why she is
okay.
doing intracervical insemination? Because of the infertility. You have to diagnose the infertility. So
Yeah.
if you have infertility and you do the baseline investigation, but just they're giving an option that if she does not want to do HSG, it's okay. You can just order it after 3 cycles. If it
Okay, يعني but in IUI we should make the basal investigation.
Yes, it's a baseline. It's part of the baseline investigation. We just mentioned all the list of baseline investigation, and HSG is a baseline investigation that even before ovulation induction, before IUI, for sure, we have to do it.
Okay, thank you.
Welcome. So the use of donor oocyte.
Donor insemination, you can do 3 IUI and then followed by HSG before the next 3 sets of IUI. It is there in the previous slide.
As it is written.
It is donor IUI.
Yeah.
Is it necessary that HSG has to be done?
Women who are ovulating regularly should be offered a minimum of 6 cycles of donor insemination. Where statement?
The next line.
And there is a lot of background noise.
Let me mute. Okay, it is muted already. This last line?
Yes, ma'am.
Yeah. So the same thing. So they are talking about unstimulated versus stimulated donor insemination. I think they're talking about donor insemination. You are right. So after 3 cycles, if they are using donor insemination, then tubal assessment can be done after 3 cycles. You are right. If treatment by donor insemination has been unsuccessful. This is your question? You mentioned that this is about donor insemination, right?
Yes, ma'am.
Yes, you are right. It is just written over here like this. But my question is again, if it's not donor insemination and they are using their partner, should she do the HSG before?
Then it is 6 cycles.
Yeah, then it is written in the mentioned in the previously 6 cycles of intracervical can be done before doing IUI. But the question is HSG should be done before this? Because it is an indication as a baseline test for all infertility patients. But I think only they are giving exception over here, the last line. This is the only exception, that she can have intracervical without doing HSG for 3 cycles. If it is unsuccessful, I think they are talking about donor insemination. And from the history, you rule out that there is no risk of endometriosis, no ectopic, previous ectopic, no surgery.
Ma'am, donor insemination, it can be performed intracervically, na ma'am. It should be done under intrauterine only, na ma'am.
Because the mechanism of
always
action
intrauterine, right?
is the same. That is true. It is in preference. The preference is in IUI because the pregnancy rate is, it's not that it cannot be performed intracervical. It can be performed, but the what you call it, it's preference because it improves pregnancy rate. With donor insemination, IUI is preferred. It's not that you cannot do intracervical, but
Okay, ma'am.
I think they ask the patient like what they want first. That's what I've seen in the clinic.
Yes. Practically speaking, they are asking the patient. Some people are not comfortable with IUI and they want to try first.
with the intracervical because you can get the kit.
Even if the patient is not having donor insemination, she can have 6 cycles of intracervical insemination before, and if she has 6 cycles of unsuccessful intracervical insemination, then she can go for IUI. It is her option. She want to try at home. For 6 cycles, she can try. It is written in the guideline. Okay. So what is the indication of donor oocyte donation? We know already, premature ovarian failure, including Turner. All these are causes of premature ovarian failure, right? Certain cases of IVF treatment failures, they can go for oocyte donation also, where is the high risk of genetic disorder transmission. How you screen the oocyte donors? Infectious or genetic diseases. Egg sharing is allowed? No, egg sharing is not allowed. Who wish to preserve fertility? So can we preserve semen, oocyte and embryos? So the chances, if you freeze semen, if you sperm freezing, and if you cryopreserve embryos, the chances success rate is higher. But if you cryopreserve oocyte, the success rate is not that much high. But the patients who are going for cancer treatment, and if she has no partner, then you can preserve the eggs or oocyte. Sperms can be freezed. There is no problem. Embryos can be freezed with good success rate. The problem is with oocyte. There is less success rate. When deciding to offer fertility preservation to people diagnosed with cancer, you have to see maybe she's a stage 4 cancer. What is the using of preserving her eggs if she is not going to be alive for her child? So you have to see that what's the diagnosis, what's the treatment plan, what is the outcome of fertility treatment and prognosis. And the embryos or the eggs or the sperms that is stored, if they later on, not all of them are going to be alive. Maybe sometimes you freeze 4 embryos, you find only 2 of them alive once you thaw them. Okay, but for cancer related fertility, the eligibility criteria is not used. Now you only have to see the cancer stage and the prognosis, the treatment plan and the diagnosis. That's it. There is no age criteria or whatever. For conventional infertility or the obesity or whatever the criteria, it's not the criteria for cancer related patients. Okay. However, will apply to, okay. When using cryopreservation in people diagnosed with cancer, use sperm, embryos or oocyte. So what is the medium used for cryopreservation for sperm?
DMSO.
Liquid nitrogen. Liquid nitrogen.
For sperms, you're using liquid nitrogen. Okay. And this is what it is written, I mean, in the guideline. There is a media for embryos and oocytes for sure. What is the difference between freezing and vitrification?
Vitrification is rapid freezing.
Rapid cooling, cold rate of freezing.
In vitrification, the inner water will be come out, so there will be no crystallization of water inside the cell.
Yeah, all the water is taken out.
So it is an advanced version of cryopreservation.
That is
so
true.
high amount of cryoprotectant will be used.
Yes, that is true. So what is better?
Vitrification.
Vitrification is better than slow freezing.
Because ice crystal formation will damage the cell also.
That is true. How many years you can preserve? 10 years. But if it's a matter
10
of
years.
Yeah, maybe cancer
If it is a
patients.
malignancy, then 55.
Oh, okay. I didn't know that. So what is the long-term health outcome? Is there a problem with ovulation induction? Or the people who are going for IVF, the kids that are born, is there any problem? Or if the
There is
woman,
no long-term studies for
yeah.
the kids, but for women there is a slight increase in the borderline ovarian tube.
Now you have to differentiate between ovulation induction and IVF. In ovulation induction, it is written that there is no direct association between these treatment and invasive cancers. Yeah, but it is written as invasive cancer. Let's see. No association and adverse outcome in children. But long-term health outcome is still awaited in women, and children is still awaited. So you have to limit lowest effective dose and duration. But let's see what they are saying here. Before, if the patient has IVF, what can happen? Okay, what can happen? Inform women that while the absolute risk of long-term IVF with or without ICSI, a small risk of borderline. So here they mention borderline ovarian tumor. Patients who are going for IVF, with or without ICSI, there's a small increased risk of borderline ovarian. Here they do not mention it. I don't know, but they are mentioning here no direct association between invasive cancer. That is true, but they do not specifically mention about borderline tumors. So I'm not sure. I mean, but here they mention it in IVF. Here they mention it specifically that there's a small increased risk of borderline. Okay. And the long-term adverse outcome is low. But here in ovulation induction, they are saying that it is still awaited. We don't know. The answer for ovulation induction, we don't know. But for IVF, there is a risk, but the risk is low. So both things, there is a small increased risk of borderline. There is a low risk of perinatal outcome, long-term adverse outcome in kids, in children, right? Which is not the case in ovulation induction. So that's why we have to bring the lowest effective dose and duration. Anyway, just I want you to differentiate between these two things. The difference between ovulation induction, which looks like, generally speaking, safe if we limit it to 6 to 9. But in IVF, there might be a small increased risk of children having, by the way, there is a talk article about perinatal risk of IVF. Have you read it? That what can happen in long term on the health of children? And there is a small increased risk of borderline ovarian tumor. Let me, because my time is finishing, and this is the last slide. We already discussed about what is the definition of poor response. What is the definition? So what is the definition of full cycle? One episode of ovarian stimulation and transfer. So at the same cycle, if there is a ovarian stimulation, at the same cycle you transfer it, then this is full cycle. Now here, follicles of 5 millimeter or less measured by transvaginal scan on day 3 of cycle. So you are measuring. So what is recommended? People are doing ultrasound on very funny days, day 13, day 14, day 15. Why? It is written in the guideline. You have to do it on day 3 of the cycle. You can do it day 2, day 3, day 4, no problem, but it is written in the guideline on day 3. So if on day 3 of transvaginal ultrasound, if you find follicles of 5 millimeter or less, and it is less than 4 oocytes, means 3. Less than 4 is 3, right? So it means that she's going to have low response. And follicles of 2 to 10 millimeter measured by transvaginal ultrasound on day 3, if it is 15 or more than 15, you see both are written here. You were right. Someone told me 20. 20 is also written here. And 15 is also written here. Whatever, we will take the cutoff of 15 because this is the lowest limit. 15 or more than 15. It means high response. But the size is given here also. And when you will do the ultrasound, day 3. What is the route? Transvaginal. And we know the poor response, less than 4 oocytes, or you cancel the cycle. Cancel means you didn't do the egg collection. it means cancelled. It means the patient has poor response. Okay, at the end of the guideline, this is for the embryologist. We don't, concentrate much on this, but and they are not asking in the exam. But just to have an idea that what is the grading system that they are using, the embryologists are using. For example, the fragmentation should not be. I think if it is more than 50%, it is not good, and the fragmentation should be as less as possible. The size of the blastomere should be, I think, it should look regular. Have you seen the embryo, at the blastocyst stage, how it looks regular, cytotrophoblast, and the and what you call it, what's the other name? One is cytotrophoblast, which is around, which is encircling the embryo.
Sensitive trophoblast.
Yes, syncytial trophoblast, which is at one side, at the fetus side, where the fetus will grow, right? This is syncytial trophoblast. So it should look regular and even division. And the diameter should be less than 20%. So all of the cells should be more or less the equal size. So it is so the grading, what they are doing, the embryologist, is according to this. And the expansion, is it a hatched blastocyst? Is it a hatching blastocyst? And the grades are according to this. Is it a expanded blastocyst, full blastocyst? And early blastocysts, they're different. So we are on day 5, it is hatching, right? Day 6 is usually hatched. But sometimes some embryos are slow. On day 6, they are hatching. I have transferred many embryos which on day 6, they are still in the stage of hatching, not yet hatched. But anyway, this is average. And then ICM grading. So these are the grades, sorry. This is the ICM is, I think, interstitial title something.
Inner cell mass.
Inner cell mass, yes, you are right. Inner cell mass. The inner cell mass grading. It is prominent from where the fetus will grow, right? And it should be like, this is good. ICM is prominent. It consists of many cells. Cells are compacted. And there is how the trophectoderm should look like at the outside. Many small identical cells. They should not be larger cells, but if it is few large cells, it's fine. And it's very bad if there are sparse large cells. I mean, this is for the embryologist. No one is asking about it, but it is given in the guidelines. So just to give you an idea. Yeah, so we finish our guideline and we touch some of the TOG articles just to have an idea.
Ma'am, can you say regarding the surrogacy TOG article, ma'am?
Yeah.
Ma'am, one more. This poor response wala slide I want to see, ma'am.
This one.
Ma'am, in this ovarian, the low response and the high response. So in one MCQ books, it has been mentioned that single parameter we can't be taken to consider whether it is a high response or poor response. We have to take a group of 3 to consider whether it is a poor or high responder. In a patient with gonadotropin cycles like AFC, AMH, FSH, all 3 supposed to be taken, not only on the basis of AFC or a single AMH level. We can comment whether it is a high response or poor response. And it is mentioned in ma'am NICE infertility guideline.
Here in this guideline?
NICE fertility guideline, ma'am.
This is the NICE fertility guideline.
Yeah, that guideline only.
But you know where they mention how you check the response, it's low response or high response. There are 3 things which are written, and they are saying that you can take either 3 of them, So even if it is a follicle which is less than 4 follicles, and the size of the follicle on day which you are checking on day 3, of the cycle by transvaginal. The size is very small, less than 5 millimeter, and the number of follicles are less than 4 oocytes, which means 3 or less than 3. It means that she's going to have low response. Even in on the basis of enteral follicle count, you can judge. Also,
Okay, means single parameter can be used.
either this, or either this.
Okay, ma'am. Thank you, ma'am.
No problem. Surrogacy needs a separate discussion because there are many rules and regulations and many things that needs to be discussed.
Okay, okay, ma'am.
Yes,
And
ma'am. Thank you.
most
I think
probably,
it was
Thank you
really
so much for this wonderful session.
thank you very much for all of you attending. Many people are not able to attend because the maximum in this GoTo meeting is 151. And to tell you the truth, I was not expecting that much. But anyway, many people are complaining that. Anyway, I'm going to post this recording because many of them are not able to attend. So I'm going to post the recording.
Ma'am, also share the PDF of.
And I want to thank you, Dr. Ghada Badran, because this is her course. She's the one who arranged and she contacted, and she's the one who is arranging. So I want to thank you, Dr. Ghada Badran, to give me the chance. Yes, anything?
And thank you for your
Ma'am,
response, ma'am. Thank you very much for your effort. It was a very wonderful lecture.
Thank you very much for you. This
Thank
is
you, Dr. Samira. It was a
I am
wonderful
IVF
lecture.
specialist, so I don't have any. So I told Dr. Ghada I will choose this topic. So thank you very much for attending anyway.
Thank you very much. Dr. Samira, just a personal question. Do you work in UK?
Oh, no. I was working in Middle East. Then I work in my country as an IVF specialist. And now I'm in USA.
Oh, you're in USA. Okay, fine. Thank you.
Okay.
Thank you, ma'am.
Good luck. Bye-bye. Good luck for all of your exams.